Yes. Good evening, everyone. Good evening. I am Samuel, and it's a pleasure to thank you all for joining the Caribbean College of Family Physicians Jamaica chapter for this evening's cancer webinar. I'd like to say I think it's our second cancer webinar for 2024. The theme tonight is cancer, a multidimensional illness. And we thank you for joining us today, Thursday, October 31, 2024. I believe it's also Halloween. Ooh, spooky. Uh, we're looking forward to a wonderful evening, however, and we have some wonderful presenters set up here for you. So thank you all so much. I'm going to hand you over now to our moderator, Dr. Aileen Standard Goldson, who is a CCFPJ executive member and past coordinator of family medicine program. Dr. Standard Goldson, over to you. Have a wonderful one.
Thank you very much, Sam. We want to welcome all. I think some are still joining. Going to give about a minute more to allow everyone to come in, and we'll start at 6:04 as advertised. Good evening and welcome to those just joining. Just giving everyone a chance to come in, and we will make a start. So on behalf of the Caribbean College of Family Physicians Jamaica chapter, I welcome you all to this webinar on cancer, a multidimensional illness. Certainly, I know that we will all, in some way or the other, have been touched by cancer in our lifetimes. And tonight we're going to look at some common types of cancer, some aspects of the disease, and some other issues surrounding dealing with the illness of cancer. We have a very formidable lineup of presenters this evening. I want to thank them all for making the time to be with us, and to thank you, the audience, for coming out in your numbers this evening. It is going to be my pleasure to guide us through the evening to make it as seamless as possible. I will be keeping time for the speakers, and I will give you a reminder in the chat when you have 5 minutes left. I will try to keep you as close to time as possible. But if there are any other points you want to make when we have the question and answer section, certainly you can make them at that time. For those who are listening, we are going to have the questions and answers at the end. So I ask you to make a note of your questions. There is a tab at the bottom called Q&A. You can type your question in there, indicate which presenter the question is for, and put your question in there. And we will deal with these questions at the end of the session. So want to make sure that I think that most people are in now. I think people are still coming in, but we're going to make a start and ask you to sit back, be attentive, and learn this evening. As is the custom with our sessions at the CCFPJ, we do start with a word of prayer. And one of our executive members, Dr. Arlene Henry Dawkins, is going to lead us in prayer at this time.
Good evening, everyone. Let us pray. Heavenly Father, Almighty God, we thank you for the goodness, mercy, and blessings that we receive every day. We thank you for the opportunity to gather virtually for another seminar hosted by the Caribbean College of Family Physicians of Jamaica. As we invite your holy presence, we come asking for your guidance, wisdom, and support as we begin this meeting, while acknowledging your power over all that will be spoken, thought, decided, and imparted during this webinar on cancer, a multidimensional illness. May the esteemed speakers be empowered to impart their knowledge and expertise on the various aspects of this serious, life-changing disease with clarity and insight. Help us to absorb this information with understanding, compassion, and a deep desire to effectively manage these patients who have received this devastating diagnosis of cancer, which affects every aspect of their and their families' lives. Mightily bless the moderators, the sponsors, the administrator, and the audiovisual team as they execute their duties. May there be an uninterrupted operation of all the equipment and a seamless delivery of all proceedings to ensure a successful seminar. We ask an outpouring of your blessings on all the participants, their families, and their support staff as they diligently strive to effectively manage these persons in their care. Strengthen, encourage, and empower the health providers and caregivers as they navigate the various challenges and successes in the journey of cancer diagnosis and care. All these we humbly ask in the precious name of Jesus Christ. Amen.
Amen. Thank you very much, Dr. Henry Dawkins. That has certainly set the tone for this evening. And I would now ask the president of the CCFP Jamaica chapter, Dr. Seni Ononushu, to bring greetings and welcome on behalf of the chapter.
Good evening, everyone. To all our attendees, presenters, esteemed colleagues, moderator, administrative team, IT and technical support staff, a pleasant good evening to you all. It is my distinct pleasure and honor to be once again a part of this evening's webinar on cancer, where we will examine some of the common cancers and the physical, mental, emotional, psychological, and ethical challenges of cancers, and hopefully assist our patients to thrive as we examine the multidimensional nature of cancer. October is celebrated as Breast Cancer Awareness Month. It is a time that affords us the opportunity to examine the impact that cancer has on the health and well-being of our patients, families, caregivers, and for many, ourselves. We wish to extend this celebration of awareness to other forms of cancer, which we will also look at this evening. The Caribbean College of Family Physicians, Jamaica chapter, in acknowledging the significance of this month and the strides we have made in cancer management and care, and also recognition of the mammoth task we have ahead of us, stand in solidarity with the medical fraternity and the broader society. As cancer is a multi-dimensional problem, it is imperative that we must adopt a multidimensional approach if we are to reduce the morbidity and mortality associated with the disease. Cancer of the prostate, breast, colon, lung, and cervix remain the 5 most prevalent cancers in Jamaica. This evening, we will be focusing on cancer of the prostate, breast, and cervix. Early detection provides the best hope for more favorable clinical outcomes and prevention when possible, and screening provides an opportunity to achieve such a goal. Likewise, adequate and proper nutrition is necessary for the well-being of these patients. The burden of cancer takes an overwhelming toll on the health and well-being of cancer patients, their families, and also caregivers. It becomes imperative that we understand, acknowledge, and provide medical support and empathy as much as possible to these individuals. Ethical considerations may and do arise when attending to the specific population of individuals. As frontline healthcare workers, it is imperative that we remain guided by our ethical codes while we dispense care as is deemed appropriate. As such, we have in our midst a cadre of experienced speakers who will delve into these topics this evening. Consultant oncologist, Dr. J.C. Copeland, consultant urologist, Dr. Rod Gafford, consultant oncologist and gynecology, Dr. Natalie Medley, consultant hematologist and oncologist, Dr. Tony Barnes, oncologist and palliative care specialist, Dr. Dindo Spence, and research psychologist, Mrs. Georgia Rose. Doctors Copeland, Gafford, Medley, Barnes, Spence, and Mrs. Rose, we welcome you wholeheartedly. May I seize this opportunity to acknowledge the members of the college who continue to attend and participate during these events, and all other allied healthcare workers for their attendance and participation. Thank you all for your attendance this evening. Do enjoy the presentations. God's richest blessings.
Thank you so much, Dr. Ananuju, not only for your welcome and greetings, but also for all the hard work that you put in. These webinars and seminars that occur throughout the year are due in a large part to your hard work, your networking, and your being able to attract such high caliber speakers to deliver on all occasions. So we thank you for all that you do. So without further ado, we are going to move in to the meat of the matter, the presentations for this evening. I remind you that the questions will be taken at the end. And if you look at the bottom of your screen, you will see the Q&A box where you can click on it and type in your questions. Please indicate who the question is directed to, and then put in the question and we will get to it later. So at this time, it is my pleasure to introduce to you Dr. Jason Copeland. Dr. Copeland is an alumnus of the University of the West Indies, having achieved his Bachelor of Medicine, Bachelor of Science, MBBS degree in 2003, and his Doctor of Medicine in General Surgery from the University of the West Indies also in 2016. He has United States medical license and he's a member of the Royal College of Surgeons of Edinburgh. He also did fellowship training at Roswell Park Comprehensive Cancer Center in Buffalo, New York. He is the founder and clinical director of the Breast Health and Oncology Care Center at the Andrews Memorial Hospital, which was started in 2020. At the Kingston Public Hospital, he acts as a general surgeon, a breast surgical oncologist, and the clinical director of breast oncology. He's also an associate lecturer in the Department of Surgery, Radiology, Anesthesia, and Intensive Care at the University of the West Indies, and a member of the World Health Organization Global Breast Cancer Initiative Working Group. Thus far in his short academic career, he has 3 peer-reviewed publications with a 4th pending, and it gives me great pleasure to ask you to welcome Dr. Copeland to present on breast cancer in men and women. Dr. Copeland, over to you.
All right, good evening, everyone. Thank you so much, Dr. Stanley Golson, for that very kind introduction. It is indeed a pleasure to be here presenting. I'd just like to thank the organizing committee of the Caribbean College of Family Physicians for the invitation to present this evening. I'm going to see if I can pull my screen up. Okay, and
Perfect, Doc. We can see.
fantastic. All right, so this evening I'll be presenting on breast cancer in Jamaica. And I'll be looking at breast cancer in men and breast cancer in women as well. The outline of the talk, I'm going to look at the incidence and mortality of breast cancer that we're seeing. We'll look at the clinical and pathological features and spend a little bit of time speaking about breast cancer surgery. When it comes on to the incidence of breast cancer in Jamaica, and this figure is based on the Global Cancer Observatory 2022 data, where breast cancer accounted for 35% of all cancers diagnosed in Jamaican women. So this was more than uterine cancer, cervical cancer, and colon cancer combined. So far and away, breast cancer is the most common cancer affecting Jamaican women. This is not unique to us. In most English-speaking Caribbean countries, we're actually seeing the same sort of trend. Now, the lifetime risk of the average Jamaican woman developing breast cancer is approximately 1 in 15, which works out to be about 7% lifetime. Now, this is different to the figures reported in the United States, where their figures are 1 in 8, or about 12.5, 13% lifetime risk. So the incidence in our population is less. The issue we have is that the burden of the disease is greater because the mortality rate is higher, the case fatality rate is higher, and the morbidity of the treatment sometimes that we offer is also higher. The projection from the World Health Organization and others is that the incidence of breast cancer in developing countries such as ours is expected to increase by about 40% over the next 25 years. So let's look at breast cancer mortality in Jamaica. And again, this is from the 2022 Global Cancer Observatory data. Breast cancer accounted for 31% of cancer deaths in our women. Again, by far greater than the other cancers, uterine, cervical, lung cancer combined. The other thing that was a bit concerning was also that there was an increase in the estimate of breast cancer mortality from the 2018 to the 2022 figures. And again, this is projected to continue to be the trend over the next 25 years. So we step back and we look at the Caribbean as a region. We found that the Caribbean region had the 5th highest cancer mortality rate in the world. And the Global Cancer Observatory, they had 21 different regions. And out of the 21, the Caribbean came in at 10 in terms of the incidence rate, but was up to number 5 in terms of the mortality rate. So we had the 5th highest mortality rate. It came in at 18.2 per 100,000, and the case fatality rate was about 36, 37. So let's look at some Caribbean countries. Now, the incidence for breast cancer in Jamaica, 71 per 100,000. Mortality rates, 35.2 per 100,000. That brings us in at a case fatality rate of about 49.5. When we look at Barbados, the case fatality rate there was about 51.6. In Trinidad, it was 41. Guyana was at 29, much lower than the others. But when you look at the United States, which we often compare with our figures to, their case fatality rate was 12.7, which means that for a woman diagnosed with breast cancer in Jamaica, she's approximately 4 times more likely to die of her disease than somebody diagnosed in the United States. I know there are many, many reasons for this, but this is something that we need to be aware of. So when we're looking and comparing our data, we're better able to understand why we're seeing these differences. So we want to look now at the clinical and the pathological features of the breast cancer that we see to see if there are some reasons here why we're seeing higher breast cancer mortality and case fatality rates. This is a study that we did at the Kingston Public Hospital and published in 2021, where we looked at the stage grade and molecular subtype distribution of the breast cancers that we were seeing in our breast oncology clinic. Retrospective study, very small, 99 patients. And we found that DCIS, or ductal carcinoma in situ, only accounted for 4% of the cancers that we were seeing in the clinic. This is not unusual because in countries where you don't have widespread population-based screening, the pickup rates of DCIS is quite low. In the United States, where you have more access to breast cancer screening, the DCIS rates there is about 17, 18%. And in other countries where they have population-based screening, you're seeing 20 and 25% DCIS rate. So our DCIS rate was quite low. The average age of breast cancer in our population was 54 years. Half of the patients had node-positive disease, and about 40% of the patients that we saw had stage 3 breast cancer or locally advanced breast cancer. We also saw a lot of patients, young patients with breast cancer. 36% of the patients were under the age of 50, and 25% of our patients were under the age of 40 years. So this is a graph looking at our age distribution from that study, and you can see that the majority of our patients are presented in that 45 to 54 years age group. When we compared it to the SEER database out of the United States, again, we can see that there's a leftward shift in terms of the age of presentation of breast cancer in the Jamaican women compared to in the United States population, where the average age of breast cancer there was 62 years. So the high incidence of breast cancer, or the higher rates of breast cancer in patients under 50, have significant implications for us, including obviously having to do with screening. What age do we start screening? And there's a lot of controversy a few years back about starting breast cancer screening at 40 versus 50. And I'm very happy that most of the guidelines have been recommending breast cancer screening now at 40. Even the US Preventative Services guidelines that for years was recommending breast cancer screening starting at 50. So we're very happy that that guideline has shifted downwards to 40. There are implications when it comes down to fertility of our women, because of a lot of women under 50. The economic impact on these women, a lot of these women may not be financially secure in their jobs or have health insurance because they're young, and there are issues to deal with psychosocial and psychosexual dysfunction as well. So what about screening? As I said, 36% of Jamaican women were under the age of 50 when they presented with their breast cancer diagnosis. This was twice the rate seen in the United States, where they only had 18% of their women under the age of 50. So clearly, our recommendations for screening have to start at 40 and not at 50. When we look at the screening in our population, we realize that there are low rates of screening traditionally in the Jamaican population. And there's a study by Suarez et al. This was from 2007, so it's a bit old, but they found that less than 5% of eligible women were actually being screened for breast cancer. when we looked at our patients that we were seeing in our breast oncology clinic, only 23% of the women diagnosed with breast cancer had any prior breast cancer screening in the 5 years preceding their diagnosis. When we looked at the SEER database out of the US, they had over 70% of patients having mammograms within 2 years of a breast cancer diagnosis. So our rates are far, far low. Now, just to mention here, when we talk about breast cancer screening, it is important that we try to understand the female's risk of developing breast cancer when you're seeing them. And there are different models of breast cancer risk assessment that can be used. There's the GAIN model, which is well known. And there's a Tyrer-Cruikshank model, which estimates 10-year and lifetime risk of developing breast cancer. Personally, I typically use the Tyrer-Cruikshank model most often, but we're able to estimate a woman's risk and put her in an average risk category versus a high risk category. And this is a simulated patient here, 45 years old, with a normal body mass index, family history of breast cancer, minority at 11 nulliparous. She has dense breast on the mammogram, no prior breast biopsy. And her lifetime risk based on the Tyrer-Cruikshank was 31.8% of developing breast cancer. The average risk in that population for that age was 10.3. So this is someone who would recommend to get annual mammography, but would also want to add breast MRI as part of her screening recommendations. So it's very important before we recommend screening that we do a breast cancer risk assessment. The Ministry of Health and Wellness in Jamaica also have their breast cancer screening guidelines for women under 40, 40 to 69, and 70 and older. And this is something that the ministry has been trying to disseminate, and they were updated earlier on this year. Importantly, for women aged 40 to 69, mammogram is recommended once per year. But just to mention here that if the woman has dense breasts, then a breast ultrasound should be added as well. And this is for persons who are at an average risk of developing breast cancer. There is no clear recommendation for imaging screening for persons under the age of 40, but breast self-awareness and breast self-examination is recommended. For persons 70 years and older, certainly if they are fit and have good life expectancy, then breast cancer screening with mammography can be continued. But outside of that, there are no clear guidelines for continued imaging after the age of 70. But if the patient is well, then you should really have a balanced discussion with the patient about the risk and the benefit of continued screening. Now, regarding breast cancer treatment, I just want to mention here, and we can't go into all aspects of it, but it's a multidisciplinary approach. And I like to say it's an integrated multidisciplinary approach where really and truly the breast surgical oncologist, medical oncologist, radiation oncologist, the reconstructive surgeon should really have the opportunity to discuss the patient in a multidisciplinary tumor board setting prior to instituting any treatment for that patient. What we don't want is to continue to have this sort of fragmented approach to the management of these patients, where a patient is seen, very often gets surgery, then is sent to the medical oncologist, then is sent to the radiation oncologist. Very often these guys have never spoken about that patient before, and it significantly impacts the management of the patient. And I'll show you why. Now, these are some of the breast cancer subtypes, or the main breast cancer subtypes that we talk about. Triple negative, HER2 overexpressed, luminal A, luminal B breast cancer. And in particular, when it comes on to the triple negative breast cancer and HER2 overexpressed, these patients' treatment is usually sequenced with neoadjuvant chemotherapy to be followed by surgery, to be followed by radiation therapy if necessary. Now, if a patient presents with a histological diagnosis of breast cancer and proceeds to surgery without understanding the molecular subtype, there's a high risk of actually doing the wrong thing for that patient. And I think in this day and age, we should not be managing patients like that anymore. So when we looked at the breast cancer subtype distribution in Jamaica, we found that approximately 21% of the patients that we were seeing had triple negative breast cancer, which is an aggressive subtype, Then we had about 7% of patients who were HER2 overexpressed and 10% with luminal B. And in this study, luminal B did include the patients who were triple positive, which means that approximately 40% of the patients that we see will either be triple negative or have HER2 positivity, and the majority of these patients would need to be sequenced with neoadjuvant chemotherapy to be followed by surgery. So if these patients are seen and are taken directly to surgery without understanding the molecular subtype, there's a 40% chance that you're actually sequencing these patients incorrectly. So we need to be getting our immunohistochemistry and our breast cancer subtype results prior to embarking on surgery. And of course, a discussion with the medical oncologist is extremely important. This is the American Society of Clinical Oncology Guidelines 2019-2020, which speaks about sequencing patients who are at a high risk of recurrence or failure with neoadjuvant chemotherapy if patients are triple negative or have HER2 positivity. And this is for patients with node-positive disease or tumor size greater than 1 centimeter. And the majority of the patients that we see actually are presenting with tumor size greater than 1 centimeter, which we'll see shortly. So this was a stage of presentation of patients that we were seeing. And as you can see here, the majority of our patients only were presenting with stage 2 breast cancer or stage 3 breast cancer. Only about 9% of our patients were presenting with stage 1 breast cancer. So again, the majority of patients, if they are triple negative or HER2 positive in our population, will need to be sequenced with neoadjuvant chemotherapy, followed by surgery. So we're going to talk a little bit about breast cancer surgery and how we decide on the surgery that we offer to our patients. It depends a lot on the clinical and the pathological features of the cancer itself, as I just discussed. The anatomical characteristics of the patient's breast. Is it ptotic? What is the density of the breast? Is it a single lesion? Is it a multicentric lesion of the breast? What is the state of presentation? And of course, we include the patient's desires. For the surgery of the breast itself, for breast cancer surgery itself, we speak about surgery of the breast and surgery of the axilla. Surgery of the breast can be breast conservation surgery or a mastectomy. If we offer the patient breast conservation surgery, this is usually followed with breast radiation, and that combination is referred to as breast conservation therapy. So breast conservation surgery plus breast radiation is breast conservation therapy. Alternatively, we may offer the patient some form of mastectomy, which could be a total mastectomy, or a skin-sparing mastectomy with reconstruction, or a nipple-sparing mastectomy with reconstruction. For the axillary component of the management, if the patient is node negative, we may offer the patient, or we really should offer the patient, a sentinel lymph node excision biopsy, because the complication rate of that operation is far less than the standard axillary lymph node dissection, where you have increased risk of shoulder pain, post-mastectomy pain syndrome, lymphedema, and so forth. Typically, patients who are node positive when they're going into surgery will have an axillary lymph node dissection. But there are some patients who were node positive, who had been treated with neoadjuvant chemotherapy, can be converted to a node negative status. And in those patients, we perform something called a targeted axillary lymph node dissection, which includes localization of the previously positive node in addition to a sentinel lymph node procedure. So this is something with less morbidity that we can offer to patients who are node positive. So I have a few examples of patients. So this is a typical total mastectomy that we're aware of. It's the most common operation that's typically done for breast cancer in Jamaica. It's a very effective treatment for breast cancer, but of course it leaves the patient with a very morbid scar, and very often the patient is left disfigured. Quality of life is not as good. It's associated with more psychosocial and psychosexual dysfunction compared to, for example, a breast conservation operation. Regarding breast conservation or wide excision, Sometimes we see patients presenting like this haven't had a wide excision surgery done. And while they have been able to retain their breast, the surgical incision sometimes can be unsightly. And of course, in both of these women, there's quite a bit of disfiguration of the breast. So also we're trying to avoid that. We're trying to avoid a total mastectomy, but also if you're doing breast conservation, we don't want to leave the patient looking disfigured. So there are quite a few prospective randomized trials that have been performed over decades, which have compared breast conservation therapy to a standard mastectomy. All trials, all of the original 6 prospective randomized trials show that there is no survival advantage of a mastectomy over breast conservation therapy. Some of the early trials did show a higher local recurrence rate for breast conservation surgery therapy, and some actually did not. Most of the, well, all of the current population-based studies have actually shown that there's no difference in well-selected patients between a breast conservation therapy and patients undergoing mastectomy for the treatment of breast cancer. And newer population-based studies, and there are a few of them actually, that show that improvement in the overall breast cancer-specific survival in favor of breast conservation therapy over mastectomy. So what are some of the indications for breast conservation therapy? Well, it has to be oncologically safe, so no patients typically who has multicentric disease, patients not having T3 and T4 breast cancer. Patient must be able to get radiation therapy, so there are no contraindications there, and we want to have a good aesthetic outcome. So here's a patient who presented with early breast cancer at a stage 1 breast cancer of the left breast, clinically node negative. And in this patient, the cancer is here in the upper inner quadrant of the left breast, which is a difficult area to operate on. You don't want to put scars there. And so we went with periareolar incisions for this patient and tunneled up to find the cancer, remove the cancer, orientated for the pathologist, and the patient was able to have her surgical incisions closed and proceeded to radiation therapy. This is a patient who had hormone receptor positive breast cancer and did not need sequencing with neoadjuvant chemotherapy. This is another patient who presented with a cancer in the right breast. Again, this was a patient with early breast cancer. This was stage 1. Similar incisions were placed here, periareolar, removal of her cancer. And this is her a year after surgery, where she has completed radiation. You can see some radiation changes to the skin. And she was able to maintain the shape and the symmetry of her breast. Again, she was hormone receptor positive, had radiation therapy, and is cancer-free. She was very motivated to keep her breast and did not want to have a mastectomy. Another patient here, she presented with stage 2A breast cancer to the left breast at the 12 o'clock position, again, an area where you do not want to put a cut on the breast. So we again went with periareolar incisions for her, remove her tumor, close the defect in the breast, and then close her incisions around the areola. She also had radiation therapy, hormone receptor positive, and again is doing very well at this point. Now, we commonly see patients from time to time with central breast cancers, and this used to be considered a necessary indication for a mastectomy. In this patient, she also had stage 1 breast cancer, so a central lesion. She wanted to conserve her breast, so we offered her what is called a central lumpectomy with a flap closure, which we call a Grissotti flap closure. So here we have taken out the nippler complex all the way down to the chest wall, and we have mobilized a dermoglandular flap here to close the defect so she does not have this sink in the center of her breast. She also was sent for radiation therapy, and this is how she looks post-op, having had a central lumpectomy with a Grissotti flap closure, and then had post-excision radiation therapy. She's also doing pretty well. Now, there are sometimes a mastectomy is indicated, and in this young lady, she presented with a triple-negative breast cancer of the right breast. Now, she at stage 2 and was sequenced with neoadjuvant chemotherapy, had a good response to the chemotherapy, had a BRCA mutation, and therefore required a double mastectomy. She opted for bilateral nipple-sparing mastectomy with immediate breast reconstruction, where we took out all her breast tissue using some mammary incisions, and then she went on to have implants placed in the same operation. So sometimes a mastectomy is indicated, and if the patient presents early enough or has had a good response to neoadjuvant chemotherapy, a nipple-sparing mastectomy with immediate reconstruction can be offered. This is another patient who presented with early breast cancer. She had hormone-positive disease and was sequenced with upfront surgery. Again, she had bilateral nipple-sparing mastectomy with immediate breast reconstruction in a single operation. Sometimes we see patients who have significant ptosis of the breast and will require a reduction type of surgery. This patient actually presented with bilateral breast cancer, triple negative, was sequenced with neoadjuvant chemotherapy, had a good response, and was able to get a bilateral skin-reducing mastectomy with immediate implant reconstruction. So what about the axillary lymph node component of the surgery? As I mentioned before, very often patients are treated with axillary lymph node dissection, but the morbidity is high, and it should not be done in patients who are clinically node negative. These patients really should have a sensitive lymph node biopsy procedure done because there's no survival or recurrence benefit of performing axillary lymph node dissection in persons who are node negative. And as I said, morbidity is high. In patients who are node positive up front and are converted to node negative after neoadjuvant chemotherapy, we can perform a targeted axillary lymph node dissection where we're only taking out that previously biopsied lymph node that was positive along with sentinel lymph nodes. The morbidity of these procedures is far less than axillary lymph node dissection, and the false negative rate is very low at 1.4%. So we also described a technique for a targeted axillary localization procedure, which we published last year, 2023, where we use TC99 direct injection into a previously biopsied and clipped axillary lymph node. We're able to successfully retrieve the lymph node with minimal morbidity to the patient, and the lymph node was pathologically negative after neoadjuvant chemotherapy, thereby sparing the patient axillary lymph node. Therefore, we can spare patients axillary lymph node dissection, provided that the node is negative. Regarding male breast cancer, we do see men with breast cancer as well, and reports out of North America, Western Europe, says 1% of all breast cancer occur in men. But in men of African descent, we've actually seen that the rates are much higher. When we looked at it, we saw 3% of all breast cancers occur in men in Jamaica, and in some sub-Saharan African countries, they're seeing 4% of all breast cancer occurring in men. In Jamaica, the average age of breast cancer in men is 68 years, and when patients present, they're more advanced at presentation than their female counterpart, and they therefore have higher breast cancer mortality rate, especially in men of African descent. So in summary, breast cancer in Jamaican women has distinct biological features which we need to understand. The incidence in men is low, but they present at a later stage in their diagnosis. The breast cancer treatment that we offer our patients, both men and women, should be uniquely tailored based on their individual tumor characteristics, including the molecular subtyping, and the sequencing of therapy should be directed based on that. Multidisciplinary treatment offers the best outcome, and we can actually decrease the surgical morbidity of what we offer, especially if the patients present early and they are well selected. Not all patients will require a mastectomy. So we can de-escalate the breast and the axillary surgery in well-selected patients. So there's a few remarks and recommendations. I'm a strong believer in breast cancer research in our local population here in Jamaica and in the Caribbean, and also in training more breast cancer specialists, both breast surgical oncologists, medical oncologists, and the radiation oncologists. We have seen where in countries where there is an active breast cancer research program that is being undertaken, that they're seeing a reduction in the breast cancer mortality rates. It's not just screening and early detection, but also better understanding the breast cancer that you're seeing in your own population, which will allow you to treat your patients a lot better. This was a review of breast cancer research in the Caribbean over 42 years. So it was published in 2018. And what they found was that there was limited breast cancer research being done in the Caribbean. Most of the studies were descriptive and focusing on clinical and pathological features. You can see most of the studies were done in Puerto Rico, Jamaica, Trinidad and Tobago, and Cuba, and to a lesser extent in the Bahamas. The majority of the studies actually were done between the years 2007 and 2017. This study actually cut off at 2017. It is hoped that since that time, we have a lot more studies being done on breast cancer within the Caribbean, but it's a significant deficit area for us. So I'd like to thank you very much for your attention, and I'll be happy to take your questions. Thank you very much.
Thank you so much, Dr. Copeland. You were exactly on time, and an excellent presentation as you reminded us that breast cancer is the most common cancer in our female population in Jamaica, and also that the mortality rate is higher than we would want. You made what we know is a very complex treatment seem simple and very understandable to us all. So we thank you very much. There are some questions for you. You can go ahead and look, and we will get to answering them later. So thank you very much.
So, Doc, please don't type the answer to them just yet so that we can ask them later on.
Yes, you can just look at them, but don't type any answer in. So, Sam, I'm correcting that I'm moving right on to the next speaker at this point.
Sure.
Right. So, we move from what is predominantly a female problem, although we heard that men are also affected by breast cancer and very severely so when they are, to what is a male cancer, the prostate cancer. And I want to introduce to you Dr. Rayod Gafoor, who is a urologist who is dedicated to benign and malignant disease with specialized expertise in minimally invasive surgery, urinary stone disease, cancer surgery, and kidney transplantation. At present, he is a consultant surgeon with a private practice who is also employed to the Kingston Public Hospital. Another graduate of our University of the West Indies, where he got his MBBS in 2001 and further specialized, getting his doctorate of medicine in urology in 2030. He attended McMaster University and the University of Toronto for elective training during his residency, and then subspecialized with fellowship training in minimally invasive surgery, uro-oncology, and stone disease, as well as he received an honorary appointment in kidney transplant surgery at the Monash Health Services in Melbourne, Australia. Dr. Gafoor is a member of the American Urological Society, the Society International Urology, the European Association of Urology, and he is the immediate past president of the Jamaica Urological Society. He is managing director of the Elective Surgical Center, Art of Surgery. He is an avid tennis player and loves to travel. So it is with great pleasure that I invite Dr. Gafoor to speak to us on prostate cancer.
Thank you very much for that, Dr. Golson, and thank you, Dr. Onanuju, and the Caribbean College of Family Practitioners for inviting me here to talk about a topic that I am personally very passionate about, and also one that gives men a great degree of anxiety when we start talking about prostate cancer. And I suspect family practitioners and primary care physicians also have sort of thought frame that it's really a specialist disease. And I encounter a lot of family care physicians who think and who would say, you know, after I've checked the PSA and it's more than 4, I hand it off to you. But as urologists, as a community of urologists, we do recognize that, if I can share, we do recognize the impact of family care physicians, primary care physicians, I should say, in being part of a team and a team approach. At the end of the day, you know, the primary care physician is the one who knows the patient best. You will see the patient first and more often than we do. We rely on you to identify and refer men who are at risk for having suspected prostate cancer. And so we want to talk about the term shared decision making, which is one that we hope we will all engage in terms of identifying men who are appropriate for screening. And so we need to know what the risk and the benefit ratios are when we talk about risk, when we talk about shared decision making. We rely on you to disseminate a lot of the accurate information that we try to get out there. And I'll tell you, at the end of the day, I have often spent 30 minutes, 40 minutes counseling a patient on whether they should be screened or a biopsy or whether they should have surgery or radiation. And after that 40-minute consultation, they'll say, "Doc, that's all well and good, but I'm not making a move until I talk to my family doctor." And that's the way it should be, really. You know, we do depend on you to overcome a lot of the cultural barriers to screening, in particular, you know, the physical exam, the prostate exam, and so on. And we also rely on you to help us to manage patients who go back into the community, who have stable disease after they've had an attempt at cure. And in terms of monitoring their lab investigations and side effects of medications and monitoring them for complications of treatment, and even giving androgen deprivation therapy. That's a 3-monthly injection, and so they don't have to come all the way out to a specialist clinic for that. So if we look at the objectives of this speech, we do want to talk about the evidence for and against screening. Should we be screening patients, and what are actually the screening guidelines that are most up to date? The workup of the patient who is at risk or suspected of having a prostate cancer. And then I'll share some of my caveats with you. Sorry, I think I lost my screen share. There's some of the caveats that I've picked up over the years in terms of PSA testing and screening. And then what happens to your patient after they're referred to us? How do we take the ball from there and run with it? And then if there's time, we'll talk a bit about the risk factors. I do believe that the topic of treatment in terms of surgery and radiation may be a bit outside of the constraints of this discussion, particular time constraint. So we won't discuss surgery and radiation in this talk. But if we look back at medical school days and we try to define what is an ideal screen, it really is one that is inexpensive, it's readily available, easy to administer, and it's 100% sensitive and specific. But in particular, when it comes to prostate cancer, what I want to do is hone down on the last 2 points. That it is a common disease, and that screening makes a difference in disease outcome. And those are the factors that we use to determine whether the risks outweigh the benefit of the screening test. So is it common? Well, prostate cancer is the most common cancer in Jamaica, and it's the #1 cause of new cancers in men. It's the #1 cause of all cancer-related deaths in Jamaica, with an incidence of 78 new cases per year per 100,000 population. So that translates to 2,300 new cases every year in Jamaica. It's common, but it also has a high mortality rate, amongst the highest in the world, close to Barbados and Haiti. We share, unfortunately, we're notorious for having that, that hallmark. Worldwide, 1 in 8 men will be diagnosed in their lifetime, and 1.4 million new cases worldwide annually. It is the most common cause of death after lung cancer annually. That's a lot, 14% of all new male cancers. Conversely, it is luckily very curable with a 97% cure rate when disease is detected early. Unfortunately, only 30% of men would survive when it is detected at the stage of metastasis. So this underlines the importance of screening to detect early disease. The chart on the top is the age-standardized incidence on mortality worldwide. So we see that incidence is second behind breast worldwide, and the mortality is third behind breast and lung. But if you look at the bottom chart and we zone down on our region, that's Latin America and the Caribbean, prostate cancer far exceeds the others, and we jump to the top with incidence and mortality. And the WHO estimates the all cancer burden of the region by the year 2040 will increase by 2/3 to 2.4 million cases per year. And when you factor in that prostate cancer is now the most common and the highest mortality rate in our region, that is a significant burden of disease we're talking about. With the advent of PSA, we've noticed slow, steady, and an exponential increase in the incidence worldwide with the advent of PSA up until about 2005. And at about 2012, the US Preventative Task Force published its recommendation after studies that showed no benefit from prostate cancer in overall survival. We'll talk a bit about that shortly. But their recommendation was that we no longer screen. And you can see the effect that that had on the picked up rate of prostate cancer. The incidence has slowly decreased over time. So that is how important PSA alone has been in detecting cancer. The study on the left, prostate, lung cancer, ovarian study, and the US Preventive Task Force studies showed similar results, that despite in slowly increasing incidence over the years, the range for mortality rates was essentially very stable. That is, pickup of cancer was not resulting in cure of cancer. However, this is controversial, and in my opinion, better studies with longer follow-up, such as the one on the right, the European randomized study of prostate cancer prevention. This was done in multi-institutionally across many European countries, and you can see that there was a slow increase again in the incidence, but a definite and significant downtrend in mortality rates. The incidence is in blue and mortality is in yellow. And these are the studies that we tend to think now are the more accurate studies. And we'll say why in a minute. But the results of the US PSTF recommendation are, as predicted, a decrease in the incidence of low-grade prostate cancer. So we're not picking up indolent cancers, we're not screening as much. But conversely, the rate of diagnosis, especially at final pathology, for high-grade and intermediate diseases, patients who had very high PSAs over 40%, and those men who had locally advanced disease at the time of diagnosis, that is seminal vesicle invasion and lymph node disease. And in particular, when it comes to lymph node disease, which traditionally signifies non-curable disease now, that in particular doubled. And all of the other incidences increases, as you can see. A retrospective study assessed that 25,000 to 30,000 preventable prostate cancer deaths resulted annually in the United States alone from this recommendation to stop screening. The weaknesses of that study were several-fold. There were procedural and statistical errors. The data was immature. There was a 50% contamination rate with patients who were pre-screened populations who were being included in the study. Men of particularly high risk, that is Black men and those with known genetic mutations, were not included. So they were disproportionately included in the study. And only 30% of men who had abnormal PSAs and fulfilled the criteria for biopsy went on to get a biopsy. Finally, it focused on survival, overall survival, and not on morbidity and quality of life. So there were many flaws that in the end, these statistical weaknesses led to the recommendation and the conclusion that screening does not result in overall survival. Multiple studies now show up to 50% improvement in long-term cancer-specific survival and in screen populations. And that really is the key term, cancer-specific. And we've realized now that that is the end term, the endpoint that we should be focusing on. This forced the task force to reverse its position of 10 years ago. And now it recommends screening in men aged 55 to 70. So when we cherry pick, so to speak, the best results from the ERSPC study, that is, for example, the Rotterdam section, the Dutch population, up to 27% of patients at 25 years, that's very relevant, long-term follow-up, were at lower risk of dying from cancer. So that result favored screening. And if we look at number needed to screen and number needed to treat to prevent one prostate cancer, not death, we saw 246 and 114 respectively. And the number needed to prevent one metastasis, 121, and a very low number of 7, the number needed to treat. When we compare that to other well-established and accepted screening programs like breast screening, the number needed to screen to prevent one death is 746. That is 3 times the number needed to screen to prevent one prostate cancer death. So why are we really having this conversation? Why is this really an ambiguous topic at this point in time? Comparing the effect of screening of mammogram on metastatic disease pickup rate compared to prostate cancer, we can see that prostate cancer screening resulted in significant decrease in the incidence of prostate cancer. So it's common, prostate cancer is common, it's deadly, it is specific to our region, or impactful, as it is 70% more common in Blacks and whites. It affects, we want to identify men who are asymptomatic, and remember that prostate cancer is, the symptoms are non-specific. So you may have lower urinary tract symptoms, you may have pain on ejaculation, you may have blood in the urine, blood in the semen, acute retention of urine. None of these are specific to cancer. You can get them with BPH, you can get them with prostatitis, you can get it with prostatic abscess. The symptoms that are more indicative of cancer are also indicative of late-stage disease, so spinal cord compression, bony pain, sclerotic lesions on radiography. Unfortunately, by the time you have those, it's incurable disease. So we want to cure when cancer can be detected early, and we can decrease death from cancer. So the answer is a resounding yes, we should be screening. But the downside to screening is the risk of detecting indolent cancers and thereby risking overtreatment of cancers that men would otherwise have lived with and died with and not died from. So we will talk a bit about how we can mitigate the risk of overdiagnosis and overtreatment. But let us take a slight change of approach now and talk about the recommendations for screening. So the consensus statement, the basic statement that we can all agree on is that clinicians, whoever they should be, primary care or specialists, should engage in shared decision-making. That is, talking about screening, whether it should be appropriate and taking into consideration the patient's life expectancy and comorbidities, for one. Reason being that prostate cancer is slow growing, that the natural progression, the natural history is that it won't affect you or kill you, or you won't develop metastatic disease for 10 years from the development of a cancer. So if you look at two arms, men who are treated and men who are not treated, cancer is slow growing, and for 10 years, there will be no difference in the benefits of life, of survivability. In other words, the cancer would not have affected you for 10 years. So there's no point in screening men who have less than a 10-year life expectancy. They will die of other causes. In addition, we have to take into account persons' preferences, their expectations for treatment, their personal religious, cultural values. So if a patient is unlikely to accept therapy that you would offer if they were found to have a cancer, they would not be tolerant to cancer, to surgery or radiation and their side effects, to adjuvant androgen deprivation therapy. It would be unreasonable to screen that person and to subject them to the potential results of a positive screen, that is biopsy and treatment and so on. So it is definitely shared decision-making we're talking about. We have to talk about the harms and benefits of screening. Namely, the benefits can be listed here. We can identify patients before symptoms develop, fast-growing cancers at an early stage when more treatment modalities are available, and we're not stymied to just one or two options now. And by early screening, we can get a baseline PSA, and so we can monitor men who are advancing in their PSA and their risk of prostate cancer, right? The drawbacks, on the other hand, is that PSA is fairly non-specific, and it is not very sensitive. It has a sensitivity rate of about 91% in all fairness, but it's got a high false positive rate as well, leading to over-investigations and false reassurances of not having a cancer. There is the risk of possibly needing a biopsy should you be found to have an abnormal PSA, and the significant adverse effects associated with the biopsy. There's a 3% sepsis rate. And we may detect cancers, again, that are indolent and would not have affected that patient. In order to mitigate this, there is now the use of multiparametric MRI of the prostate that has been introduced. And up to 25% of men may be spared a biopsy with the use of MRI. So we do have ways and means of decreasing the risk of prostate cancer. We look at the specific recommendations now by the American Urological Association. Number one, do not screen men younger than 40 because it's so rare for a man to have a cancer, it's not worth the risk. The greatest benefit, or a sweet spot, so to speak, is between 55 and 70 years of age. If the man has less than 10 years to live, it's advised against screening in the over 70-year-old patient. We are moving towards increasing the trigger for biopsy to 10 and above, 10 nanograms per ml in this group, and to stop screening if the PSA is less than 3, because these men who are over 70 rarely ever die of prostate cancer if their PSA is less than 3. When should we start screening? So for the average risk patient, and the next slide will show you who is the high risk, so everyone else is average risk. We should start at 4 to 5 years of age, between 45 and 50. And if their PSA is less than 4 at this baseline, we can consider offering screening at 2 to 4 year interval. And if it's greater than 4, but greater than 1, but less than 4, we can consider 1 to 2 year intervals. We should offer regular prostate screening every 2 to 4 years for the average risk man who's between 50 and 70. And we should stop screening after 77 years of age for the average risk. If the PSA level is less than 1 at 60, no further screening is necessary. So for the higher risk patient, that is the black men, which is pretty much the majority of our population that we will see, The patient who has a known germline mutation like BRCA1, BRCA2, checks, Hobox, microsatellite instability, and a number of newer mutations that we're discovering. The patient who has a family history of prostate cancer or one of the associated cancers like breast, ovarian, and pancreatic. These men are deemed higher risk, and you should start screening at 40 to 45 because they develop cancer 3 to 5 years earlier than their average risk compatriots, and it kills them 5 to 10 years earlier than your average risk persons. There are other societies like the European Association of Urologists with very similar guidelines. For the low-risk patient, they have no adverse family history. Their PSA is less than 1 at 40 years of age or less than 2 at 60. The interval should be 2 once the PSA is greater than 1 or greater than 2 at 60. The average risk patient should start screening at 50 and the high risk at 45. And men with BRCA mutations should start screening at 40. So similar guidelines. There's a lot to digest here. If you have any questions, feel free to reach out to me, and a lot of these guidelines are available online for you to digest at a slower pace. But the bottom line is that what we all agree, these guidelines give us the freedom to personalize our screening approach to each man. So again, shared decision-making and personalized screening based on their baseline PSAs, their age, their life expectancy, their preferences, their general health, and so on. So the emphasis is really now put on the clinician-patient relationship and not on strict guidelines. Some of the caveats that I would share with you, some of the things I've picked up over the years, and this is a consensus statement, you should use PSA as the first screening test, right? And if it is less than 10, we should get a second PSA reading before we say that person has an elevated PSA. So I will typically wait 8 weeks before repeating it. And I would only consider a biomarker or further imaging or biopsy if I have a second PSA in that patient with a PSA less than 10. I don't order a PSA if the patient has had a UTI or if they've ejaculated or had vigorous exercise in the past 48 hours or a biopsy in the last 8 weeks, because you can get a falsely elevated PSA. PSA is sensitive, but not specific. And so, most men with an elevated PSA will luckily not have a cancer. We do use age and race specific reference ranges to decrease the number of men that we're going to investigate further, thereby decreasing the risk of overdiagnosis. So men in their 7th decade, I use 4.5, and men in their 8th decade, I'll allow you up to 6.5 before I say that you really have an elevated PSA. That's not to say that I won't investigate a healthy, physiologically young man who has a PSA of 6 or 4.5 who's 70 years of age. Each man is different, and each man it should be individually approached. I don't treat men who are asymptomatic with empiric antibiotic therapy to lower their PSA. A lot of men will ask me, Doc, how can I get my PSA down? Or even physicians will call me and say, I've done this and this, and the PSA won't go down. So I don't really treat the PSA, and I don't lower the PSA. And why would you? The PSA is akin to a fire alarm in your kitchen. Would you turn it off? Would you turn off that alarm or mute it? No. What you want is for it to not to go off and wake you up every time someone lights a match. What you want is for it to go off when you have a real gas or a grease fire that's threatening to burn down your house. You should be aware that Duodart and Avodart and finasteride will decrease your PSA by 50%. So if a patient has been on that for about 6 months, I will double it to get the true value. And I do use the free to total ratio that you can just tick that on the blood form and they'll give you a ratio. And if it's less than 10, then there's a real risk of a cancer being there. And if it's greater than 25, it's less likely there's a cancer. So this is particularly useful in the patient with a PSA of 4 to 10, where you're trying to decide what to do. Is it worth it to do a biopsy or not? Further to that conversation is use of the PSA density. So that is the PSA divided by the volume as ascertained either on ultrasound or on MRI. And if it's greater than 0.25, there is a significant risk of a cancer. And if it's less than 0.15, it's hardly likely there will be a cancer. And I do not use the PSA velocity as a screening tool. So the DRE is the one that gets men nervous, and we probably lose a lot of patients to screening for this. And here's how I mitigate that. What do I do? And the consensus statement is you do not use DRE by itself. You only use it alongside an elevated PSA to establish risk in asymptomatic men. So that is, I don't do a DRE unless you have an elevated PSA. And the reason being that it is very non-specific and non-sensitive. I do use it in symptomatic men to rule out infections, prostatitis, abscesses, and in those men, I would then try to treat that underlying illness and then reassess the PSA. Remember that the prostate cancers, the majority are formed in the transitional zone, and a lot are formed anteriorly, but you really only access the posterior aspect on the DRE. So many cancers are impalpable. All right, the DRE is useful for staging disease and feeling extraprostatic disease and seminal vesicle invasion, but other than that, the use is limited. 80% of patients who had a biopsy performed for an abnormal DRE did not have prostate cancer. And in those who did have a cancer, 25% of them were in a location different from what the DRE would indicate. So with a PPV of 42%, you're actually better off flipping a coin than really doing the DRE. So again, it's not recommended as a screening tool in the asymptomatic man. What adjuncts to PSA and the DRE exist? The ultrasound is notoriously bad at differentiating malignant prostatic tissue. It should not be used alone for diagnosis. I get reports all the time that there's a hypoechoic lesion or calcifications on ultrasound, and so a cancer should be strongly entertained. I really don't place much value in the the ultrasound, and it cannot be used to identify at-risk men. However, the MRI has really revolutionized what we do and helps us significantly to avoid unnecessary biopsies and resultant complications. The precision trial, which compared men who were treatment naive and who had elevated PSA, one arm went on to have straight biopsies and one arm had MRIs, and only the suspicious MRIs had a biopsy. And 28% of men who had the MRI were avoided an unnecessary biopsy. In addition, it helps us to, so in so doing, it helps us to decrease the detection of insignificant cancers because we really only biopsy suspicious lesions, PIRADS 3, 4, and 5, and I would ignore PIRADS 1 and 2 if just taken on that face value alone. So there's a high sensitivity rate for significant cancers. It also improves our false negative rate. The transrectal ultrasound has a false negative rate of 25%. So 1 in 4 cancers are missed because you can't see a cancer on an ultrasound. All right. Prostate cancer is the only solid organ cancer that we try to detect blindly without having any imaging up to the time of MRI, without having any imaging to try to focus or target. With breast, you do a hook wire. With other solid organs, you have some imaging that shows you where to target. But until MRI came along, it was a blind biopsy, really. So we missed a lot of cancers. In addition, MRI helps us to stage the patient, which has implications for curative intent. The latest frontier in stratifying patients who are at high risk is the bioassay. And these are blood or urine tests, and even tissue bioassays can be done on biopsy specimens to identify men who are at low risk of a significant cancer. And in particular, men who have a PSA less than 10. So how I use it is in a patient who's had an MRI, their PSA is still suspicious. But we want to avoid a second biopsy. The MRI is no longer is equivocal, and so I will refer them to have a assay done. And it has excellent negative predictive value. So if it is negative, you can fairly safely avoid another biopsy and tell your patient it's unlikely to have a cancer. So the latest additions to the bioassay, and these are FDA approved, is the My Prostate Score, Prostate Health Index, or the PICE Index. 4K is the most common and popularly used. There's the PCA3, ISO, PSA, Select MD. There are a number, and each year it seems like there are more. So that's the latest frontier. And lastly, what happens when your patient is referred to us? Most primary care physicians will order the screen test. What happens when the PSA is abnormal if it's above 4? And what I would say is don't wait until it's 4. The cutoff and the latest recommendations for cutoff for referral to specialists is 3 nanograms. It doesn't mean that every patient with a 3.5 will get a biopsy. It doesn't mean every patient with a 5 will get a biopsy, but it means that now we do look at a lot of the other adjuncts in terms of risk stratification that are at our disposal. Will we use MRI? Will we use a biomarker? Will we proceed straight to the ultrasound, a transrectal ultrasound, or a transperineal biopsy? There are many options. And, the transrectal ultrasound has a significant sepsis rate because it's really a transfecal ultrasound, isn't it? And so those are decision-making tools that we will go through once a patient comes to us. And should they unfortunately be diagnosed with a prostate cancer, we'll then risk stratify them as very low, intermediate, or high risk based on the Gleason score, the volume of disease, the PSA, and the clinical finding. And in addition, now we'll use the tissue-based genomic markers like the Ccfp, Oncotype, or Prolaris to determine who can get active surveillance, or who should have surgery, or who should get adjuvant therapy after surgery. So in summary, in order to avoid overtreatment, we have these tools at our disposal. Really, the genomic classifier is the latest and really the most interesting, because if we are able to identify that you have a genomic risk factor like BRCA2 or 1, then you're at high risk for harboring aggressive disease, and you should not get active surveillance. You're at high risk for harboring aggressive disease, and so you're likely to recur, and so you should get adjuvant therapy. The last slide really is, because I think my time is up, is our, how we avoid overtreatment. The first step of treatment is we realize that most men who are screened have indolent disease and they do not need treatment. If we can observe them closely every 3 to 6 months with a PSA, we can do a confirmatory biopsy at 1 year to make sure that we've not missed aggressive disease, plus or minus an MRI. Then we're really able to detect cancer when it does upgrade with enough time that we do not lose the window of curability. And in so doing, only 27% of men will upgrade who are being actively surveyed. So we're able to alleviate and the side effects of treatment, mitigate the side effects of a treatment, and really that's what we want to do. And so screening is no longer so dangerous. So we can offer active surveillance for the low risk, or curative intent like surgery, radiation for those who are at higher risk. And some men who have very high risk disease or who actually recur after surgery, radiation, will need more multi-modality approaches, which is surgery and then radiation. We tend to not do radiation first because the side effects and complications is very high. If you try to operate on a radiated field, they get heavy bleeding and their risk of incontinence is very high. So in conclusion, we do want to espouse shared decision-making. We want you to have a good appreciation of what the risk-benefit ratio involves, screen appropriately to avoid overdiagnosis and overtreatment. And the bottom line is individualize our patient care. And we are happy that you have an appreciation of the newer tools that are available to us. So thank you. I know it's been a lot, but I hope that we're able to garner some questions and some robust discussion afterwards.
Thank you very much, Dr. Kapoor. That was very timely. Certainly, I like that you emphasized the need for shared decision-making shared decision-making, shared management between the primary care physician, the specialist, and of course the patient. And also you answered a lot of the questions that we have about the screening guidelines and how they relate to our specific population. So I do thank you. You can look at the questions. Don't type in your answers because we will take them live later on, but you can prepare yourself for the questions. Thank you very much for another excellent presentation.
Thank you very much.
We are moving on to our next presenter, who is Dr. Natalie Medley. Dr. Medley attained her Bachelor of Medicine, Bachelor of Surgery, MBBS, with distinction in obstetrics and gynecology and honors in general surgery at the University of the West Indies in 2008. She has a passion for women's health, which drove her to pursue a career in obstetrics and gynecology, and she completed her residency in 2015. She then went on to complete a fellowship in gynecological oncology and an editorial fellowship with the International Journal of Gynecological Cancer, where she now serves on the early career editorial board. She has recently been accepted to the editorial board of the Obstetrician and Gynecologist, a leading peer-reviewed journal in the field. She works privately and is also a consultant obstetrician and gynecologist and gynecological oncologist at the University Hospital of the West Indies, and serves as an associate lecturer at the University of the West Indies. She enjoys these roles because it allows her to do her clinical work, to teach residents and medical students, and to conduct research, which has resulted in a few publications. Her interests outside of work include music, being on the worship team at her church, exercise, art, and photography, and must make note that she enjoys watching movies with her son, Michael Keith. So Dr. Medley, we see you have a very rounded life. We welcome you tonight to speak to us on screening for cervical cancer, the role of HPV. Over to you, Dr. Medley.
Okay, thank you very much for that warm welcome. And I want to thank Dr. Onanuju and her team for inviting me to share with you today. I'll be speaking to you briefly on screening for cervical cancer, the role of HPV testing. I have no disclosures, and my objectives really are to share with you 10 key roles of testing for the human papillomavirus, or high-risk strains of the human papillomavirus, or HPV. So when we hear HPV testing, persons often think, what is this new thing? Is it something that's going to replace pap smears? Should we now be thinking out with the old and in with the new? So in the early 1900s, George Papanicolaou made the discovery of abnormal cells in the vaginal washings of women who later turned out to have or had cervical cancer. And then the pap smear, as we know, took off and became the primary screening methods for years and has been very useful. And fast forward about 100 years later, we see Harold Hussein receiving the Nobel Prize for his discovery of HPV and its link to as a primary causative agent in cervical cancer. So the first point I want to share with you is the pivotal role HPV testing plays in the WHO Cervical Cancer Elimination Initiative. So to give you a bit of background on what this is, in 2018, the Director General of the WHO issued a call to action for the elimination of cervical cancer as a public health problem. He stated that we now have the knowledge and the tools to stop women from dying from this preventable disease. So cervical cancer is indeed a public health problem. It's one of the most common cancers among females. It's the fourth most common after breast, colorectal, and lung. And there are about 604,000 new cases in 2020 and about half the number of deaths. And unfortunately, most of these cases and deaths occur in developing countries like us, for us here in Jamaica, about 85 and 90% respectively. So this elimination strategy is actually the first global health strategy for eliminating a cancer as a public health problem. And achieving these 90, 70, 90 targets by 2030 would result in over 62 million deaths from cervical cancer being averted by 2120. So what are these targets? And so by 2030, each country should aim to have a 90% vaccination coverage for all girls by age 15. 70% of women should be screened with a high-performance test by age 35, and this is where HPV testing comes in, and again by age 45 years. And in terms of treatment, 90% of women with cancer or precancerous lesions should be managed. So elimination targets is really 4 per 100,000, which we're aiming for over the next many years, but achieving the 2030 targets will put us well on the way to getting to this elimination target of 4 per 100,000. Currently, the global average is about 13 per 100,000. In the Caribbean, we're at about 13.7, that's a bit above the global average. And we can see here some countries like Western Asia are already at the target of 4 per 100,000. So in Jamaica, we don't have a formal screening program, but we have been making very good strides with the reduction in cervical cancer incidence, coming down to about 15.7 per 100,000 in the last review. But looking at each of these targets and how have we been doing? Starting at vaccination. So WHO states that vaccination of adolescent girls is the most effective long-term intervention for reducing the risk of developing cervical cancer. The HPV vaccination program started in 2017 as a school-based program. The targets were 20 to 22,000 girls each year. But the uptake has been well below these targets. So we can see in the first year about 2,000 girls, about 10%. This increased steadily up to 2019, but unfortunately around the time of the pandemic, we can see the numbers fell off dramatically and still has not gotten back to where we should be with our vaccination. Fast forward to treatment, 90% of women should be treated with cancer or precancer should be receive treatment. Dr. Tufton some years ago stated that the cost to treat women with just radiotherapy alone, the 392 cases per year was about 274 million. And this is only for radiotherapy. Doesn't include diagnosis, doesn't include chemotherapy or surgery. And it doesn't address the loss of earnings by these women because oftentimes cervical cancer patients are young women. They're not able to then take care of themselves and their families. And the mean age is actually 45 to 50. So it really is a younger cohort that's affected. So that now brings us to screening using HPV testing as a primary screening test. So looking at the target again, 70% of women are screened with a high performance test by 35 years and then again by 45 years. So because of its high level of performance, its high sensitivity, the WHO states that countries should ideally be transitioning to HPV testing as the primary screening method for cervical cancer. And when we look at HPV testing versus pap smears, because of the high sensitivity, a woman can be screened at 35 and again at 45. Because of the lower sensitivity of pap smears, we would not be comfortable with such a wide screening age group or screening number of years. So why HPV testing? We know that pap smears work. So in countries which have implemented robust screening programs, they don't have cervical cancer as a major problem in their countries. But in developing countries like us, here in Jamaica, we face many challenges in implementing a formal screening program. We need healthcare workers to collect the samples. We need laboratory personnel to process and interpret the results. We need effective follow-up and treatment. And oftentimes this is where we fall off in contacting women, giving them the results. Many patients, or many physicians will know a patient. You ask them if they did a pap smear. They said yes, but they didn't get a phone call, so they assumed it was okay. So there tends to be some disconnect there at times, right? There are limitations of pap smears as well. I mentioned the sensitivity is about 51%. False positive rates vary as well. And so there are several challenges. Persons may state, well, we have liquid-based screening versus traditional slide or cytology. But studies have shown that liquid-based screening versus conventional pap smears actually have the same sensitivity. But HPV testing offers superior sensitivity. The strong negative predictive value means that women who test negative only need to be retested after a minimum interval of 5 years. In less developed regions, the use of 1 or 2 HPV DNA tests in a woman's lifetime would be sufficient to make an impact on mortality. With the availability of rapid test kits, those testing positive can immediately be treated. And those testing negative would be at low risk of cervical cancer for at least 10 years, and hence the target 70% by age 35, and again 45 years. Here we see some of the commercially available test kits. The hybrid Capture 2 was one of the first implemented, and most other tests were approved based on comparison to hybrid Capture. And we can see 97, 90, all over 90%. Some we have 100% sensitivities. And this is an example of how a HPV test report will look that we have available here. So we can see if a patient is positive, if she's positive for type 16 or 18 or 45 versus any other type. So we have very useful information here, and this impacts on how we manage the patient with a positive HPV test result. So it's important that we have a breakdown showing the different types of the high-risk types. So HPV testing actually represents a natural progression as our medical knowledge advances. So again, Dr. Papanicolaou making the discovery, and now we look at when we look at a slide, cytology or pap smear, we see abnormal cells. So this is an HPV infected cell. It has a multi-nucleation and a perinuclear clearing or halo. We call this a koilocyte. And you can see this looks very different from a normal superficial squamous cell. So the pap smear looks at these features and can tell you that this cell represents an HPV infection, and other features as well that signify high-grade infection and so on. With HPV testing, however, there's no laboratory interpretation needed in that sense, and it's really HPV DNA detection. So the sensitivity, of course, is a lot higher. So we do know a lot about HPV. We know the link to cervical cancer. So it represents a natural progression that we would then test directly for HPV in screening. A bit more information on HPV. There are many different types, and not all HPV causes cancer. There are over 200 subtypes broken down into species and genera, and all the high-risk types are actually found here in the alpha category here, and there are about 12 high-risk types. So all the different types, 12 types which are oncogenic or cancer-causing, and they're shown here. Of all these high-risk types, type 16 and 18 account for the majority, 70% of cervical cancer, type 16 alone accounting for 50% of cancer cases. So those two are the highest of the high-risk types. This diagram here just depicts the viral caspid, and the aim is really to show you that there are several proteins associated with HPV, but the two troublesome ones are E6 and E7, and when these are detected, they mean that malignant transformation is taking place in the cervix because they are tumor suppressor proteins. And we'll see why this is important as we move on to the next point, future high-performance HPV testing. So most HPV infections clear within 1 to 2 years. So it's the norm for HPV infections to resolve. So having an HPV infection is very common. 80% or more of women who are sexually active will come across some infection in their lifetime, but it's a norm for it to clear. Ideally, we want to have a screening strategy that will tell us if this patient who is HPV positive is likely to go on to develop malignant transformation. And because we don't have that information right now, there tends to be an over-referral to colposcopy for women who test positive for HPV. So there are ways around this. We use the pap smear result to kind of guide us into who needs colposcopy. We also know we look at the HPV genotyping for 16 or 18, and if it's positive for one of those two, they go immediately to colposcopy. And I'll share this with you again later on. So the fact is, it would be good to know if this HPV infected patient is on our way to a malignant transformation. Unfortunately, we do have some of these test kits available. There's this one called the E6, OncoE6 test. So it detects E6 and E7 oncoproteins, the cancer-causing types. So if a woman is positive for HPV and has E6, E7, we know that there is some malignant process underway. So this is a transforming HPV infection versus a transient one that's usually going to clear on its own. So that's showing us the OncoE6 there with sensitivities varying right now. So it's still made experimental, but there is a lab here which actually offers, has E6 testing available. Another biomarker which is being looked at is the P16INK4A, which also gives us an idea of whether E7 is being expressed, and these cells are on their way to malignant transformation. Another key role of HPV testing is that of co-testing. HPV testing partnering with cytology or pap smears, and this has several benefits. Just wanted to share with you the screening guidelines from the American Cancer Society in 2020, where they actually moved their age up from 21 now to 25, and they recommend primary HPV testing alone every 5 years. That's their primary recommendation. And this is if an FDA-approved HPV test is used. If a FDA-approved HPV test isn't available, then they recommend using whichever other HPV test available with pap smears every 5 years, or pap smears alone every 3 years. So co-testing increases the screening interval from 3 yearly with pap smears alone up to 5 years alone if you have pap smears with the HPV. In this guideline, though, they stated that as the US makes the transition to primary HPV testing, the use of co-testing or cytology alone for cervical cancer screening will not be included in future guidelines. So they're looking to move away completely from cytology or pap smears. And also another benefit of co-testing is that it helps us to manage abnormal HPV test results as well. This is just briefly showing our local guidelines. We actually start screening at age 21 every 3 years using cytology alone. When a woman gets to 30 to 60, she can use cytology alone every 3 years or HPV testing every 3 years. And this is in the average risk woman. In women who are high risk now, women who are living with HIV, for example, which we know these women are 5 to 6 times more likely to develop cervical cancer, then we screen them every year. Also, women with any immunocompromised states, women who are exposed to diethers, silbustrol in utero and so on, then they're screened starting at age 21 as well, but every year across the age groups from 21 up to 64. But when they get to 30 is when HPV testing can be implemented as well, just as seen with the low risk woman. And this final diagram here is just to depict how co-testing can help us. So a woman is positive for HPV, then we look to see is it 16 or 18, and if it is, she goes straight to colposcopy. If it's any of the other 12 high-risk types, then we do a pap smear, which would be so much of a reflex pap smear. And if it's normal, then she follows up in 12 months. If it's abnormal, then she goes to colposcopy. And if it's negative, then of course, routine screening, whether it's 3 yearly or yearly, depending on her risk category. Now let's look at reflex testing for ASCOS. So ASCOS, or atypical squamous cells of undetermined significance, is actually a very common pap smear finding. And it's undetermined significance, as it states, we're really not sure. Most ASCOS is not HPV positive. About 1/3 to 2/3 of cases are not related to HPV. So if a woman has ASCOS, what's recommended is doing a HPV test. And if she's HPV positive ASCOS, then she should be referred for colposcopy. And this management guideline really came out of this large multicenter study called the ASCOS LSIL triad study, which found that HPV triad was useful in patients who had ASCOS. The sensitivity was equivalent to immediate colposcopy, and it reduced the need for colposcopy referrals by 50%. And this is important when we think of the cost of colposcopy, the psychological trauma associated with going for a colposcopy, and overtreatment that could occur from unnecessary colposcopies. Also, it identified 96% of women with ASCOS who actually needed further treatment because they had a precancerous lesion. They found, however, that most cases of LSIL, low-grade squamous intraepithelial lesions, were associated with HPV, about 83%, and as such, HPV reflex testing was not recommended for LSIL. So these women generally are sent to colposcopy. So let's look at treating women who have cervical intraepithelial neoplasia. So you have a woman who has an abnormal pap smear. She goes on, does colposcopy, she has excision, she has ablation, and we're now following her up because we need to follow these women closely after colposcopy. We don't leave them and tell them to continue regular smears a year later or 3 years later, because there is a risk of recurrence. So there are several guidelines which incorporate using HPV testing in following up these patients or post-treatment surveillance. And in the UK, they have what's called a test of cure, which utilizes HPV testing and a pap smear at 6 months after treatment. And if it's negative, then they can continue 3 yearly screens. So they found that, and this came from several studies, but they found that doing this actually allows women to return without any risk of missed disease or earlier recurrence. And similar findings in the United States, where they use HPV testing at 6 months with pap smears, And this is how they follow up their women who are managed for CIN. And now rapid testing. So HPV testing does allow for rapid testing. There are some test kits, for example, Care HPV, which can give results in as fast as 3 hours. The Expert HPV can give results in as little as 1 hour. There are some advantages of the Care HPV though. It can detect 16 and 18 individually, which I mentioned is very useful because these are the highest of the high-risk types, and if a woman has 16 or 18, that's an indication for direct colposcopy. So having this information is very important. Or 45, which is very common in our setting locally, and it detects the remaining types collectively. The test platform can be used for other tests as well, such as HIV and STD detection. The major limitation, however, is the cost. Now let's look at HPV urine testing. So the sensitivities vary, but the high sensitivity of HPV testing generally may allow us to use urine samples to detect HPV. So we know for STD screenings, for example, urine tests can be done for chlamydia, gonorrhea, trichomonas, and so on. The pool sensitivity is about 77%, with a specificity of about 94%. But further studies are needed. So this isn't something that's been done clinically right now. And finally, I wanted to end with HPV self-sampling. So HPV testing has the advantage over pap smears of women being able to screen themselves. So patients involved in HPV self-sampling studies consistently reported improved convenience, less discomfort, and positive attitudes generally with the same self-sampling option. Earlier studies actually showed a 10 to 19% decrease in the sensitivity when comparing self-sampling to clinician-collected samples, but more recent studies actually show that it's comparable. Several countries have already included HPV self-sampling as an option for women for cervical cancer, and it is supported by WHO. So endorsement of self-sampling, though, by clinicians is less certain. Limited studies show that most clinicians would support self-collected HPV tests if it were highly sensitive and cost-effective. And in our setting, I actually did a study earlier this year. Some of you may have seen the questionnaire being circulated. Thank you for those who participated. And we did find that most persons would have been supportive or in support of primary HPV screening in our setting and also HPV self-sampling. I did want to share this with you though before closing, the entity of HPV-independent cervical cancer. So I stated many times during the presentation, and we've all been told in medical school, 99.7% of cervical cancer has HPV DNA. However, more recent studies in the last decade have found that about 3 to 8% of cervical cancer is actually HPV independent. And this is important. We see these entities in adenocarcinoma and squamous cell, and they tend to be more aggressive than HPV-associated cervical cancer. They have early nodal involvement, more distant metastases, and thus generally poor oncological outcomes. They're associated with a different pathway from HPV-dependent cervical cancer, so we see more P53 mutations and KRAS and so on. So the WHO recently recommends all pathology reports with cervical cancer to state whether it's HPV positive or not by using the P16 immunohistochemistry staining. So in summary, HPV testing represents a natural progression as cervical cancer screening. In cervical cancer screening, it has improved sensitivities over pap smears and is the way forward for primary screening. Triage tools such as pap smears and HPV genotyping are useful adjuncts in preventing over-referrals to colposcopy from HPV screening. Newer technology allows the detection of transforming HPV infections by identifying E6 and E7 oncoproteins. HPV reflex testing is useful in managing women with ASCOS, preventing over-referrals and over-treatment in these women. And HPV self-sampling is approved by the WHO and has been shown to improve screening rates, especially in women remote from healthcare services. HPV testing is a pillar in achieving the cervical cancer elimination targets, which all countries, including Australia and Jamaica, need to be working towards achieving in the next 6 years. But we know cost is a significant factor in implementing HPV testing. However, according to the Director General of the WHO, the success of the drive to eliminate cervical cancer depends on political will, country-led action, investments, global solidarity, and sustainable and adaptable partnerships. So on this note, I'd like to thank you for your attention.
Thank you so much, Dr. Medley. I feel as if you have taken us in very firmly into the 21st century, showing us the value of HPV screening and how it can be utilized not only in primary care, but as you say, patient self-screening is also available. So we do appreciate the clear, concise way in which you took us through that topic. And I'm sure that we have all gained knowledge from it. So thank you very much.
Dr. Standard Golson, if I could interject here, I would recommend, based on the time that
Yes.
we're doing, that we do 6 minutes Q&A here, so we could release our first 3 presenters, and then the next 3 presenters, we'll take them at the end.
Yes, I think that is an excellent idea. Thank you very much for that, Sam. So I was just about to say that we have looked at some of the specific disease entities and how we deal with them, and we are now going to go on to some of the other issues around cancer. But as Sam has suggested, we're going to take the questions for the first 3 presenters at this time, and then we will move on. So I'm going to go ahead and ask the question. So I'd ask Dr. Copeland, you are up. I'm just going to try and, okay, the first question that was there, Dr. Copeland, and I'm just checking that Dr. Copeland is with us and hearing me.
Yes, I am with you.
You are here. Okay,
Thank
fine,
you.
fantastic. Has obesity been associated with breast cancer in the Caribbean experience? Was the first question.
Yeah, so in general, breast cancer, obesity is thought to be associated somewhere between a 25 and a 50% increase in breast cancer generally. Specifically within the Caribbean, I'm not certain of any local data that looking at it. There is a social determinant of breast cancer that was looked at before. And the thing with some of these studies is that, there are confounding factors. But there was evidence that, in persons who have increased alcohol intake, obesity, increased hypoglycemia, and so within the population, that those things tend to be associated with an increased risk of breast cancer. But as a singular specific factor, I can't say that I'm aware of the data.
Thanks for that. Rand Hasfell is asking, is saying, if we are seeing a left shift in age of diagnosis and 25% of breast cancer patients are under the age of 40, should we be thinking of moving the recommendation lower for screening to 35 or 30? Asking your opinion here.
Yeah, it is something that we struggle with. Very often when we look at the statistics within the Caribbean, a lot of Caribbean countries see a lot of breast cancer in young women. The thing is that we don't have the data to support it. Most of the information comes from more well-developed countries where they're not seeing that. And when they look at their mammographic studies, they're not seeing the support for doing mammographic screening for persons under the age of 40. They're not seeing a mortality benefit. Nonetheless, I think in our population with a high rate of breast cancer in the young is something that we should look at. I think with the new techniques for screening, such as 3D mammography and using digital mammography, we actually may have better sensitivity than what the old studies suggested for screening in young women under 40. So I do agree, something that we should look at. We don't have the evidence currently to support it, but it's something that we should look at in our population. Nonetheless, we do advise that for women under 40, breast self and clinical examination is what we usually recommend.
Thanks for that. There was some controversy some time ago about the value of breast self-examination. What are the current thoughts on that?
Yeah, you see, when studies that had looked at breast self-examination, a lot of it was in first world countries. And where you have regular screening mammography being done, they did not find a benefit for breast self-examination. The problem is when you try to extrapolate that into countries where you don't have that access to breast cancer screening, and then to say, breast self-examination is not effective. Now, other countries such as India have looked at it, where they have low rates of mammographic screening, and they actually find that there's a benefit to breast self-examination and clinical breast examination. So we should not run to say that there is no benefit of it, because when you interpret the data from high-income countries where they have access to mammographic screening, it really does not apply to us. So we believe that you should continue your breast self-examination and your clinical breast examination.
Thanks for that. Going to shift. There might be a few more for you, but I'm going to shift now to Dr. Gafoor. And Dr. Brown Morgan is asking, will the PSA increase with chronic prostatitis? Would the PSA be repeated a month after any antibiotic therapy? And how do we assess PSA in that situation?
I'm sorry, could you repeat it? I missed the first part, and I'm not seeing where that question is texted.
Okay, it is saying, will the PSA increase with chronic prostatitis? Would the PSA be repeated a month after any antibiotic treatment? And how do we assess the PSA in this situation? Are there adjunctive tests that should be done?
Right, so the PSA really is, as we said, it's non-specific to prostate cancer. It really is released by the basement membrane of the glands when there is inflammation, damage, cancer, trauma, and those things will release PSA in a higher level. So into the blood where it's detected in a serum test. So yeah, prostatitis can present with a falsely elevated PSA. So what, again, if the patient is symptomatic and you have an idea that there is something else going on, there's a differential diagnosis, then I would treat that patient with antibiotics. Prostatitis, chronic prostatitis is traditionally thought to be 6 weeks of antibiotics. And then once you have finished a course of antibiotics, we would wait 3 weeks before repeating the PSA. The reason being you want 7 half-lives to pass for it to return to its baseline. And the half-life of PSA is about 3 days. So that's how I would approach that. I would treat and then repeat after an appropriate interval. And other things that can falsely elevate the PSA, like acute urinary retention and some of the other things that we mentioned early, ejaculation and exercise and so on.
Thank you. Dr. Bandara Kaur is asking, is prostate MRI available here? What is the cost? I know there would be a range, but maybe you could speak to that.
Yeah, sure. Prostate MRI is readily available. Yeah. We do have issues with machines going down from time to time. The two centers that have a T3 weighted MRI, which is what you need, we no longer do endorectal coil MRI. We need a T3, which is well, I don't want to, call any private facility names, sure. But there are at least 2 facilities here, and as well as University Hospital, that you can get an MRI. The average cost is about 85,000. Let's just say that, and the only caveat is that the machines are highly being used. It's a high volume usage. And so they do go down quite often these days, unfortunately. But, usually within 2-3 weeks, they're serviced and back up again.
Okay, another question here for you, which you may have to type in the answer. I don't know if you can answer it right now. How can clinicians manage erectile dysfunction in patients with prostatic disease or prostate cancer? That seems like a rather extensive question.
That may be beyond the bounds of this conversation.
Yes, I think so. If you have a little time before you leave, if you want to type in something there that Ms. Hines can see. The question is also asked, is it important to include DRE with PSA as routine screening? But I think you had mentioned to us that you would do the PSA first, and only if it's elevated, then you would go on DRE. Did I get that correct?
Right, that's the recommendation, that we don't use it as a primary screening tool in the asymptomatic patient.
Right. Okay, thanks. I'm going to move on to some questions for Dr. Medley. Dr. Gafoor and Dr. Copeland, you could just look in the Q&A if there are any others that I missed that you could type in some answers for. Dr. Medley, you are with us?
Oh yes, I'm here.
Okay, Tamara Gordon is asking, for patients with PCOS 40 years, how often would you recommend pap smear to detect if they have cervical cancer? What is the likelihood for persons with PCOS to have cervical cancer?
Okay, so PCOS isn't a known risk factor or doesn't increase the risk of cervical
Right.
cancer. So PCOS alone, she would still be screened. If it's only PCOS as a low risk patient, it will be every 3 years starting at 21. So the main conditions which would alter screening would be women living with HIV, women on immunocompromised or immunosuppressive drugs, anybody with an immunosuppressive state, or women who already had abnormal pap smears, then we'll screen them more often here. So with the PCOS itself, what she should be concerned with that there is an increased risk of endometrial cancer, or womb cancer of the lining of the womb, but not cervix. So if there is no
Okay.
other high risk factor, then she could regulate.
All right, I saw a question that someone was asking about the kind of cost for HPV testing in Jamaica. Can you comment on that?
Yes. So right now there's really one lab that does it privately, and it's $11,000 for HPV testing.
Okay, they were asking about the lab, but I don't think we would want to call the name of the lab here. We can probably do a message offline.
Okay, well,
Okay. I think I will stop there. There are a few more questions there, but in the interest of time, we're going to move on and ask our speakers to, if they could take some time and just type in the answers to the ones we haven't covered. And as I know they may want to leave us, I would take this opportunity to preempt the vote of thanks and to thank Dr. Copeland, Dr. Gafoor, and Dr. Medley sincerely for taking the time out to be with us this evening and to make their presentations. So thank you very much. If you can stay, you are of course welcome to stay. And we thank you very much for your presentations this evening. As I mentioned, we're looking at cancer as a multi-dimensional illness. And one of the very important dimensions in any patient, in any person, is nutrition. And I want to introduce to you Dr. Tony Barnes, who is a medical doctor specializing in hematology and medical oncology. She received her training at the University of the West Indies, graduating with her MBBS in 2012. She completed her internship and senior house officer training at the Cornwall Regional Hospital. And in 2015, she started postgraduate training at the University Hospital of the West Indies and worked as chief resident of the Hematology Oncology Department before completing her Doctor of Medicine in Hematology and Medical Oncology in 2020 in the midst of the COVID pandemic. After postgraduate training, she worked as a senior resident at the Kingston Public Hospital. Since November 2023, Dr. Barnes has been working as a consultant physician at the Hope Institute Hospital with a dream to advance cancer treatment in Jamaica through research and education. When not working, Dr. Barnes enjoys sport shooting, playing video games, and lounging on the beach. We can all visualize that right now. But today, her remit is to talk to us about nutrition in cancer patients. So Dr. Barnes, I'm handing over to you at this point.
Hi, good night. Thank you for that introduction. I Here we go. So I'd like to talk today about nutrition in patients who have cancer. It's a really big and important topic for us because I think one of the most common questions I get from my patients is, Doctor, what can I eat? And so there are so many studies that have shown that patients who have been diagnosed with cancer have malnutrition, and we have found that up to 85% of patients with cancer are found to be malnourished. And malnutrition really refers to deficiencies, either excesses or imbalances in a patient's intake of energy. And the term malnutrition covers both overnutrition and undernutrition, with overnutrition being a risk factor for many types of cancer, and undernutrition being sometimes a reason that patients end up being diagnosed. Malnutrition increases the toxicity of many treatments. It also diminishes the patient's quality of life and can increase their mortality rates. Many patients actually experience unintentional weight loss as the first sign of them having cancer, and that leads then to their diagnosis. So why is nutrition important in this population of patients? Well, there are many important reasons, and the role of nutrition in cancer is very broad. It improves treatment tolerance and reduces side effects for the patients. There is support of the patient's immune function. It promotes healing and recovery, which is needed after many of the treatments that they receive, enhances their quality of life. It may improve their treatment outcomes and also provides a holistic approach to patient care. So what are some of the difficulties that we face with nutrition in patients who have cancer? There are many impediments. Some of them are tumor-related effects. Some of them are treatment-induced effects on the patient's nutrition status, and there are psychosocial factors as well. For the tumor-induced effects, usually it is associated with the disease site when you have a cancer that is in an area along the gastrointestinal tract. So we're talking about the head and neck cancers, the esophagus, the stomach, the pancreas, the intestines. And we see things ranging from dysphagia or dinophagia, changes in taste, to things like early satiety, nausea and vomiting, diarrhea, malabsorption, and so on. We also find treatment-induced effects that affect the patients, and these range broadly between the different types of treatments that we have available. So chemotherapy very commonly causes things like nausea, vomiting, diarrhea. You have changes in taste, you have changes in appetite. These things also occur in radiotherapy. Patients who receive radiotherapy, particularly to the head and neck, have problems with the mouth, have mucositis, have difficulty with saliva production, and those things can affect their ability to eat and swallow. Biotherapy here refers more to things like immunotherapy, which then causes things like colitis. It can cause stomatitis, and it can cause difficulty with almost all the areas along the gastrointestinal tract. There are also psychosocial factors that affect our patients, things like changes to appetite, especially when the patients are depressed or anxious, patients who are over or undernourished because of stresses related to their disease, as well as patients who have problems with their mobility and because of their issues with using their hands or moving their feet, they need assistance from family members with food preparation, and sometimes that assistance is not available. So how do I know if my patient is malnourished? There are actually many screening tools. Instead of just looking at a patient and saying, oh, they look cachectic, there are tools that we can use as doctors to assess the patient, and there are tools that the patients can use to assess themselves. And these tools can help us to know when is an appropriate time for us to make a referral to a dietitian or a registered dietitian and nutritionist and so on. There are also biochemical markers that we can use to assess for patient's nutrition, things like the urea and creatinine, which can be very helpful to decide if the patient is dehydrated, for example. We can use the albumin to know an assessment of their liver function or sometimes of their protein intake. And then we can use physical markers, things like whether or not the patient is cachectic, if they're adequately hydrated on examination, and so on. So this is a good nutrition tool that is used. It is recommended by the American Society for Clinical Oncology and it's called the malnutrition screening tool. And basically, we assign a score to the patient based on how much weight they have lost, what their appetite is like, and based on the score that they receive, we can decide whether or not they need a formal nutritional assessment from a registered dietitian. We also have the PGSGA, which is a patient-generated global assessment. And this is a questionnaire that the patient actually fills out by themselves, and we can assign a score to them based on what different answers that they have given based on weight loss, appetite, the types of food that they're able to consume. And with this, again, a score is assigned to them, and that helps us to know if this is somebody that's going to need perhaps enteral or parenteral nutrition, and whether or not we need to refer to a dietitian later on. So coming up with a nutrition plan is something that should be based on each patient. The nutrition plan should be tailored to the patients individually, because appropriate nutrition can help to combat cancer's impact as well as the treatment side effects. And the key areas that we should focus on for this would be alleviation of treatment side effects, supporting the patient's resilience and recovery, as well as enhancing their quality of life. So these are just some rough dietary guidelines that we can use in order to help patients plan. Sometimes it doesn't really work out this way, where we can tell them an exact number of calories, especially when they're having difficulty eating, but it can help us at least to tell them an amount that they should aim for. So for calories, we try to do it per kilogram of body weight, 25 to 35 kilocalories per kilogram per day. We want at least 1 gram per kilogram per day of protein. We want fats, particularly healthy fats in the form of omega-3s, to take up about 20% of the patient's diet. And we want the patients to have carbohydrates, focusing mainly on complex carbohydrates rather than simple sugars or processed carbohydrates. Lots of patients ask about supplements, and I think in most clinics, somebody will come with a bag of vitamins that somebody sent to them from abroad and say, "Doctor, can I take this?" And I think the most important thing that we need to remember is that the best supplementation of vitamins is actually from food. So if a patient is able to consume a vitamin in the form of a food that vitamin naturally occurs in, it is always better than using supplementation, because food is its most bioavailable form. We have to also try to tailor these things to what the patient may need. So vitamin D is one that I really recommend to patients a lot of the time, because there is actually data available that shows perhaps that vitamin D can reduce cancer mortality, and has found that patients who are diagnosed with cancer are more likely to have a low vitamin D than patients who do not have cancer. For the other vitamins, for example, iron and B vitamins, there is a lot of low energy that comes with having cancer. A lot of these patients have anemia, and of course, the anemia needs to be investigated. But a lot of the time, these patients perhaps have bleeding. So the patients with cervical cancer may have PV bleeding. The patients with rectal cancer may have PR bleeding. Sometimes because of malabsorption, perhaps with gastric cancer, we may be deficient in B vitamins. And so we should always test for vitamin deficiencies, but these patients often can benefit from supplementation of additional vitamins. Antioxidants are nice to talk about. They are helpful, particularly in patients with inflammatory conditions and patients who are receiving things like immunotherapy. But we have to be a little bit careful, because studies have shown that high antioxidant burdens, especially people who take antioxidant supplements rather than people who take antioxidants in the form of like spinach and berries and nuts. Sometimes those antioxidants can react with the chemotherapy and make it less effective. So I would say antioxidants, as they are naturally occurring in food, are good, but antioxidants as an extra supplement may be not very helpful while on chemotherapy. Herbal supplements are a very big thing. a very big deal, especially in Jamaica. And sometimes it's a little bit confusing because a patient will come and say that they have this bush that grows in their yard and they're telling me the name and I've never heard of it before. And I know certainly the guidelines that I use never heard of that before either. So they actually have this interesting app by Memorial Sloan Kettering Cancer Center that they have actually put together a lot of different herbs and plants that may be used in herbal medicine to try to help physicians know what medications may react with what kinds of plants that the patients may be using. Sometimes it's also difficult because they use the scientific names, but I do think that it's a very helpful resource. So there are goals that we want to put in place for people who have cancer. And those goals, the nutritional goals, would be to try to maintain or improve their body weight and maintain or improve their lean mass. So we don't want anyone to lose muscle. We don't want anyone to lose any more fat. It may be difficult for them to build, but at least they won't be losing anymore. We also want to try to support their nutritional function, their immune function, and we also want to try to minimize the burden of symptoms and the burden of side effects of treatment that they're going to receive. Of course, this approach is going to be personalized because all of the patients have a different stage of cancer, they have a different type of cancer, their needs are different, their psychological aspect is different, and their social support is different as well. So it does have to be tailored to each patient, but if we use these simple tenets, I think all of the patients will end up with a better outcome. So there are some specific dietary recommendations that I do want to speak about as it relates to some of the more common effects of the cancer or of the treatment that I see. One would be nausea and vomiting, a common side effect of chemotherapy, as well as an effect of the cancer itself. So for patients who are receiving treatment and have nausea and vomiting as a side effect on top of their regular medication, we usually recommend that they consume bland foods, crackers, rice, toast, things that are lighter in color tend to be more bland. Conventional antiemetic therapy is very good at preventing vomiting, but not very good at preventing nausea. And so conventional medicine hasn't really solved the nausea problem very well. Some of the guidelines, particularly the American Society of Clinical Oncology, use ginger as one of the adjuncts that they recommend. And there have been meta-analyses that show sometimes that ginger may help to improve nausea, but the reviews are mixed. We still recommend it though. I don't think there's much of a harm in telling patients to use ginger, and anecdotally, it seems to work. We also recommend patients have small, infrequent meals and try to avoid strong odors, take small sips of clear fluids in between their meals, and try to drink broth. Poor appetite is another one that comes up very often, sometimes because of the cancer itself, sometimes because of the treatment that they're receiving. We also recommend that these patients try to have small, frequent meals, up to 6 meals a day. And we want those meals to pack a punch. Whenever the patient is able to eat, we want them to eat food that is very dense, very high calorie, that is high in protein, things that are easy to get done, like shakes, smoothies, eggs, nut butters like peanut butter, almond butter, cashew butter, full fat yogurt, olive oil, avocado, cheese. So fatty things, high protein things, high calorie things, because if you're not going to eat a lot, every time we eat, we want you to get a lot of nutrients in that one portion. Sometimes they say that appealing presentation of food will help the patient's appetite to improve. I don't know if I believe that so much, but it's worth a try. Maybe if they like things that are colorful, lots of fruits and vegetables, you have pretty cakes and pretty ice creams, maybe they would want to eat more readily. But I don't know if that's necessarily true. And also flavor enhancement that the patient can tolerate. So obviously, if we're having nausea and vomiting, we're not going to be adding too many herbs and spices. But if it's just a poor appetite issue, then maybe spicing the food a little bit more can be more helpful than giving the patient something bland when their appetite is low. Mucositis is also a common complaint from chemotherapy, from radiotherapy, from head and neck cancers, from people who are on immunotherapy, and it can get very bad. We also recommend things like soft and bland foods, as well as avoiding irritants, so spicy food, acidic food, things like citrus, tomatoes, things that are rough, like tough crackers. We want to try to avoid those things because they can affect the mouth negatively. We also want to think about the temperature of the food that we're offering to people. We should tell them to try and have things that are room temperature or cold, because those are more soothing to an irritated mouth than things that are hot. So yogurt, smoothies, ice cream, to people who have sore mouth is much more easy to tolerate. We also want things that are moisturizing, full of liquid, like broths and yogurt and kefir. When people have dysphagia, again, as a result of the treatment, as a result of the cancer itself, as a result of radiotherapy, soft foods, pureed foods, minced foods, and we can offer them thickened liquids, which can be commercially made, like when you give a baby thickened feeds, or we can use natural thickeners like banana, which has been mashed or blended. We also want to try to avoid dry foods and crumbly foods, which can cause the patients to choke or feel throat irritation, which makes the dysphagia worse. Diarrhea and constipation are extremely common, and they kind of are two sides of the same coin. So diarrhea, we use more low fiber foods to have the stool pass less frequently and have the patients rehydrate to replace the water that has been lost. Whereas with constipation, we want to tell them that the patients need to have more high fiber foods, oats, whole grains, fruits, and vegetables, and also an adequate amount of fluid intake. Neutropenia is a really big one. It's a very important thing that I like to talk to my patients about, and we need to limit exposure to bacteria, fungi, and mold from food. So this includes avoiding raw foods. And by raw foods, I mean raw fruits and vegetables. So fruits are fine if they are peeled. It's very difficult to remove germs from the surface of foods. If you're able to sanitize a fruit, then fine, but it is always better to have somebody having peeled fruits rather than unpeeled fruits. And then for vegetables, I prefer when they have cooked and steamed, sauteed vegetables rather than raw ones, because it's much harder to sanitize things like lettuce. We also want to cut down on things like unpasteurized dairy, raw milk, certain soft moldy cheeses like blue cheese, sushi, rare steak, and runny eggs, which can all be harbors for bacteria. We need the patients to practice proper food hygiene, hand washing, avoiding cross-contamination, so making sure that they have a separate cutting board for fruits and vegetables and a separate cutting board for raw meat, and make sure that they have proper food storage techniques and temperatures. Other chemotherapy side effects that sometimes are strange, but you hear about, is that people will say that the chemotherapy makes their mouth taste very metallic. And one thing that we can do to help to reduce that taste is tell them to use plastic utensils. And I hear that it actually works very well. Also, using things that are extremely or highly flavorful, like lemon, sugar, and spices, that can help to overcome some of the taste changes that the patients experience. And then another thing that sometimes we may not think about is fatigue. So if they don't have a caregiver at home, if they're by themselves, sometimes the patients get very tired and can't cook for themselves. So if they're able to pre-prepare their meals before they have treatment, or they have things that are easy to access, like trail mix, granola bars, energy bars, and shakes, that can make it a lot easier for them to fulfill their nutrition goals. Immunotherapy, just briefly, so we know that the immune system is modulated with this therapy, but then what can happen is it can become overreactive and you have inflammatory responses. So if you can give the patient instructions to try anti-inflammatory foods such as omega-3s, using probiotic supports that you may find in yogurt and kefir or probiotic supplements, and have them have soft, easy to digest foods when they're having things like the mucositis. If they're having episodes of colitis, it can help to get them through those difficult periods. And lastly, the hormone therapy, sometimes we don't think about this because it's maybe more of a long-term effect, but the hormone therapy that they receive for things like breast cancer and ovarian cancer can result in the long term in things like weight gain, loss of bone density, and an increase in patients' cardiovascular risk. So weight management now becomes part of it because as we have spoken about in previous presentations, overweight and obesity can increase your risk of several kinds of cancer, including breast cancer. So we have to help them to manage things like the calories that they consume, tell them to improve their fiber consumption. We need to focus on their bone health by advising them regarding calcium and vitamin D intake, whether that is from foods or from supplements that they can take, and also things to mitigate their cardiovascular risk, like consumption of heart-healthy fats in the form of omega-3 fatty acids and using low sodium options when they eat. So what happens after treatment is done? Most of these things that we've spoken about have to do with nutritional support while the patient is on treatment. But what happens to the patient when the treatment is complete? Well, when the treatment is complete, even if you have had one type of cancer, that does not mitigate your risk of you getting another type of cancer. And so we also have to think about what are the strategies that we can use to help the patients prevent the cancer originally from returning or developing a different type of cancer. And there are so many studies that are available now showing that there are different foods that can increase in some cases and decrease in some cases the cancer that you can be at risk of. One of the big ones is alcohol use. We are finding more and more now that alcohol, there's almost no safe amount of alcohol for you to consume. For breast cancer, I think it is now said that up to 3 alcoholic beverages per week potentially is safe. That's 3 beers per week in total. There are some cancers that you're only allowed 2 before it increases your risk of development of cancer. And so reduction of alcohol use or no alcohol use is best. The Mediterranean diet really has been the only diet that has been found to have any potential effect on the development of cancer. And by the Mediterranean diet, we mean a diet that is rich in fresh fruits and vegetables, high fiber, high in whole grains, low in fat, except for omega-3 fatty acids, which is best from plants and oily fish sources, and cooking with olive oil. We also recommend using more fruits and vegetables, less red meat, and less processed meats and foods. And sometimes when we speak about processed meats and foods, I don't think we think about our processed meats and foods. We think about, oh yeah, potato chips and burgers and barbecue, but we don't really think about the fact that processed foods includes the things we eat very often: salt fish, salted pigtail, salt mackerel. A lot of the things that we eat in the Caribbean that you don't necessarily think of increasing your cancer risk are things that have been proven to increase the risk of a lot of different types of cancers. And then also adjustment of cooking techniques. So grilling, broiling, frying, anything that is going to cause a crust or a char has caused an increase in certain types of cancer, particularly colon and gastric. So I think once we're able to have the patient understand what healthy diet is like, potentially we could cut down on the risk of cancer recurrence as well as the risk of development of other types of cancers within the same patient. So in summary, adequate nutrition supports patients through the treatment, through their side effects, and through the diagnosis of cancer. And it helps to improve their outcomes by reducing malnutrition, improving their quality of life, and also decreasing their risk of mortality from that cancer. The dietary needs would be variable based on the symptoms that the patients are having and the type of treatment that they have received. And the nutritional needs while receiving treatment are very different from the needs before you develop cancer or after you have been treated. So I do want to make that distinction that a diet on chemo, a diet on radiation, a diet when you're receiving immunotherapy is a totally different diet than a cancer prevention diet or a diet that you should have when you are on surveillance. So thank you very much for your attention.
Thank you so much, Dr. Barnes. That was so, what would I say? You put things so simply. You gave us such practical advice for the different things that we see in day-to-day practice. You reminded us that the ever present thing of the bag of supplements, the bag of vitamins, reminding us that vitamins and supplements from food first is really best, but pointing out specific ones that could be of use in certain areas. And also reminding us that any nutritional plan has to be individualized for our patients. So we really appreciate that. And I'm sure that all who are present found it really useful. You can look at the questions. We'll take them after the other two presenters, but you could take a look so you can be prepared to answer them. We are moving on now to some ethical considerations. The person who was originally slated to do this, unfortunately, is not able to be with us, but we are extremely privileged to have with us Dr. Dingle Spence OD, who is a Jamaican physician with training in both clinical oncology and palliative medicine. She recently retired in March 2023 after 20 years as the Senior Medical Officer at the Hope Institute Hospital in Jamaica. It's the only dedicated oncology and palliative care unit in the public sector. She's an associate lecturer at the University of the West Indies and is co-founder and co-director of the Jamaica Cancer Care and Research Institute, a nonprofit organization dedicated to improving the quality of cancer care and palliative care in Jamaica and the Caribbean. Dr. Spence also serves as a visiting oncologist to the Turks and Caicos Islands and currently works part-time at the Radiation Oncology Center of Jamaica. She is a former board member of the International Association of Hospice and Palliative Care and a co-founder of the Palliative Care Association of Jamaica and the Caribbean Palliative Care Association. She has done work in Guyana and was the lead external consultant on Guyana's National Cancer Control Plan. She is a member of the Cancer Subcommittee in Jamaica, which is updating the country's guidelines for cancer care. On August 6, 2024, Independence Day in Jamaica, Dr. Spence was listed and then awarded on National Heroes Day the Order of Distinction Rank of Officer for her contribution to medicine in the field of oncology and advocacy of palliative care in cancer and health systems. We are extremely grateful to Dr. Spence, who at very short notice has agreed to talk to us on ethical considerations in patients with terminal cancer illness. Dr. Spence, over to you.
Thank you very much, Dr. Standard Golson. And thank you to Dr. Ononojo, who kind of called me up yesterday morning and said, could I jump in? So I said, yes, of course. I am going to just move straight to my slides. Thank you for that great introduction as well. Where am I now? Here we go. Share screen. Slideshow, where is slideshow? Okay. I hope
Perfect.
everybody can see my slides.
Yep, definitely we can.
That's good. Okay, thank you. So I changed it slightly. And I do just want to say that what I'm going to be talking about is not something new. This is more reminding you about where ethics and palliative care and people with advanced cancer all sit together. So consider this as a refresher, because I've given various different kind of angles of this talk before. So forgive me if some of the slides are very familiar. So I'm just going to jump right in and start. So I just wanted to briefly give you some definitions. Of course, we all know this is a four-principle model, and sometimes we're like, oh, not that again. But what I want to be able to do is just to tie some of those principles to how we actually think about our patients. And of course, one of my big things is how do we talk to our patients? And there's an awful lot of maleficence in the way that we communicate or not communicate. So I want to raise some of those issues. And then I'll just talk about three cases. Unfortunately, they're mainly hospital-based, but I am going to be asking you as family doctors to think about some of the ethical dilemmas that you face in your practice. And maybe we can discuss those in the Q&A afterwards. And of course, goals of care is one of the most fundamental things that we look at in palliative care. So we will touch on that too. And just to say, I have no disclosures today. So for me, this is a really excellent definition. And I was part of the consensus in 2018. There's many definitions. Many of you will be familiar with the WHO one. I like this one a lot. And just at the bottom line, palliative care is primarily a response to suffering. And of course, we suffer on many different levels. So it's active and holistic care of individuals across all ages with serious health-related suffering due to severe illness. And tonight, we're going to focus more on people who are towards the end of life. I think somebody's mic is open. So if the admin could just remind folks to close their mics, please. And obviously, in relieving suffering, we are hoping to improve the quality of life of our patients, and not just our patients, but those who are near and dear to them, their families and their caregivers. So this is a very helpful little slide for me. And I think it just shows you, this is where we all got trained. We have a conventional medical approach. That should say medical, not medicinal. And that's really focused on preventing, fixing, and curing. But we unfortunately don't get a lot of training or focus on how do we relieve, comfort, and support our patients who are going on this journey. And in the beginning of a diagnosis, let's say, of cancer, you may not need much palliative care. But as time goes on, unfortunately, as this disease progresses, or if you are present with metastatic disease in the beginning, you're going to need quite a lot of relief, comfort, and support. And that's where palliative care and the palliative care approach come in. And of course, this is a slide I show often that really just reminds us that there is total suffering. So not just the physical, which we tend to zone in on in medicine, but there's the whole psychological distress, which has been touched on, existential distress. Why me? I've been a good Christian all my life, and now this is happening to me. Although I have to say that the faith base that many of our patients have in Jamaica and the region often acts as an excellent palliative to the existential distress of a terminal illness. And then, of course, there's a family and social distress, and also very much important to realize that we as health professionals get distressed as well if we don't have the tools or the support to look after patients. So looking after total suffering is a team approach. No one individual can manage all of this. And that's one of the beauties of palliative care, that we can call on other people to help support us as we support the patient and their family. So what's different about palliative care? And again, I'm sure you'll have seen me show the slide before of the optical illusion as the two faces one way and then the vase. And I show this because whenever I get called to a bedside, you know, outside of the hospital that I used to work, I'm always surprised at how I would see the patient differently than maybe my colleagues might. And I think the main thing is that palliative care is really looking at the person rather than the disease. And I do hope that all the family physicians on this call, in fact, all colleagues on this call, would like to think that that's really why we came into medicine, is because we wanted to care for people. But unfortunately, our training sometimes takes us out of that and we forget we're looking after people and we get very disease focused. And so palliative care is a way that brings us back to the focus on the person. And then, of course, the person is not in isolation, it's their family and their nearest and dearest as well. So palliative care is the kind of care that you would want for someone you love if they were seriously ill. And one of the most important components of palliative care, which we'll touch on as we go through the talk, is identifying the goals of care. So again, this is one of the places where I think family physicians are really key to supporting people, because hopefully you have known this person for some time. So you have some idea what's important to them. Are they the type of person who wants to do everything at whatever cost? And, you know, if that means more chemo when the disease is advanced, and that's what they've always wanted, I'm going to fight to the end, doc. Fine, that's fine. And we can support people in that. Or are you the kind of person who says, you know, I've had some treatment, it's only worked so much, the side effects were really rough, and I really don't want any more. How can you keep me comfortable for the rest of the time that I have? And I want to see my grandson christened in 2 months' time, so can you help me do that? So goals of care are really important. And sometimes they can be as simple as, I want to be able to get out of my bed and walk on with some assistance to sit on the veranda and catch some morning sun 2 times a week. So goals of care can vary completely. And of course, how do we find out what people's goals of care are? We talk to them and we have a conversation. And so communication skills underlie all of these approaches. So very, very briefly, we know this already, but just to remind you, excuse me, that medical ethics are the moral principles that apply value to the judgments that we make to practice medicine. And they support us in complex decision-making, and they provide a framework, very importantly, for us to consider difficult cases so that we can look at ethics to support us as we move through what might be really quite challenging decision-making process. And hopefully we'll see that with a couple of the cases. So autonomy, we're all super familiar with this. Just a brief reminder, does my patient understand the interventions that are being offered, and do they want them? Because sometimes we kind of steam right ahead and assume that this is what people want, and sometimes the question has not been asked, and sometimes even though we say people are being asked to sign a consent form, there's many studies that have been carried out in the States that demonstrate that people thought they were getting curative treatment when in fact it was palliative. So how much information did they really have when they were signing the consent form? Beneficence, will this help my patient? Non-maleficence, obviously, will these interventions harm my patient? And is this a fair utilization of resources? So I'm going to stick more with the first 3 tonight. So, not surprisingly, I guess, ethical principles when people are coming towards the end of life are the same as they are in standard medical care. But sometimes things, when people are facing terminal illness at end of life, sometimes there are more issues that arise that we may not find in day-to-day medical care. So again, I'm going to highlight some of those. And the context may be unique, but the principles are really the same. And so it's very useful to keep this returning and reminding ourselves. So let's ask a few questions around these. So autonomy. how does my relationship with the patient, how does autonomy feature? So first of all, does my patient understand what's going on? Do they understand what's wrong with them? What do they think is a good outcome, and what are they hoping for? I'm looking after a gentleman who has metastatic prostate cancer at home. He's very weak on his legs. Every time he sits up, his back hurts him a lot. He's asking me, am I going to be able to get up and walk? Am I going to be cured? And so that's his good outcome, that he's cured from his metastatic disease and that he's going to be able to get up and walk and be normal. So I have to help draw him back into the understanding of what's really going on. And then that means we have to kind of shift what he's hoping for. But if we don't ask people, we're not ever going to know. So back to the communication skills. Is my patient able to make decisions? And if not, do they have a proxy? Very important. And who is that proxy? Is that somebody that they've willingly chosen, or is that somebody who stormed in from overseas and said, I'm going to make the decisions for my mother, even though I haven't seen her for the last 3 years? So all of these things, I'm sure you're starting to see, oh yeah, this happens quite often. So if we're meeting people early on who we know are going to need a proxy to help them make decisions, that conversation should happen early on in the illness. And so, as I said early, informed consent is really important. Can people participate in making a plan for their own care? And how long can they do that? And then at which point does the proxy step in? And who is the support system? So this gentleman I'm looking after has a brother who passes in now and again, and he doesn't have children. And so he really doesn't have much support. Luckily, he has a little financial means, so we can get some nursing care in there, practical nursing care in there to support him. So all of these things are really important to consider. And this is all around autonomy. So beneficence. Am I fixing what's wrong? What's my relationship with outcomes? And again, we have to be really careful, because the outcomes we may be pushing or hoping the patient may get may not be appropriate because they are not able to manage the treatment that's required. And is the treatment going to get them there anyway? So these are questions that I think are very important. And are we appropriately managing the patient's last days? Did we ask them what they want? And back to, the autonomy and the communication and making sure that we're not causing more harm than good. And sometimes I'm very glad that I'm just talking after Dr. Barnes, because nutrition can be a really challenging thing when people come to end of life. And there can be a real fights in the family over what them can eat and what them can't eat, and so on and so forth. So it can really be a minefield in that area. So I think just what I'm saying is that, there's often benefits early on to treatments, but then at what point do the burdens outweigh the benefits? And that's where the difficult decisions are. That's where the really important communications are, to find out what people's wishes are, what are they hoping for, so that we can help guide them through some of the difficult decisions. And remembering also that our duty is to the patient, but we may often have the relatives saying, no, mommy must continue with that chemo, because if she don't, she's gonna dead. Whereas mom is going, the chemo is killing me. So it's really an important point of discussion as the benefits, the burdens start to outweigh the benefits. Non-maleficence. Now, this is something that, we often think of, what do we mean by harming the patient? And this has become very clear to me over my career, that we can harm people in a way that we're not even clear that it's harm. But over and over and over again, I've heard patients speak about the insensitive way that their physician spoke to them, and they left them feeling disrespected, upset, not valued as a person, just another number. And that's maleficence. And so one of the things we need to be really careful of is, how do we speak to people? How do we share information? obviously continuing aggressive treatment that's not in the patient's best interest. I didn't do that, sorry. And so on. And then the thing about in medical ethics, withholding a treatment is seen as on the same ethical level or principle as withdrawing, because remember, we're offering medical intervention. So for instance, a nasogastric tube, would we withhold that? And that we could speak all day about these things. Or would we withdraw it because it's no longer serving, or the person really doesn't want it there? So withholding and withdrawing is a whole area that we can discuss, but ethically they are seen as the same thing. And of course, we have to be very careful of interventions that drain our patients' social and financial resources and are not beneficial to them. As I said, I'm not really going to stick around on justice. Justice is a huge issue, but we'll move on from that today. So, you know, we often also have to help our patients navigate the therapies that are being offered. And I remember, as you know, Dr. Gafour said, I did hear a little bit, he said, I want to talk to my family doctor first. Or they may say, Doc, don't ask me because you're the doctor, so you choose. But of course, we're not going to push people down the road of treatments that we don't feel is going to benefit them. And we should have had a big background discussion with them and their family about what would be most appropriate. So as you can see, we're talking about shared decision making. And I put this picture of a family from India because I spent a little bit of time there, and it's very different than the West. The patient defers all decision making, certainly in the cultures that I was working in, to the family. So the patient says, my family is going to make the decision and I will go along with that, which is quite different in the West, where really the duty of care is to the patient, and they can call in the family members that they would like to support them. And then so the autonomy is very different in Western cultures than it is in certainly in India, where I spent a little bit of time. So that took a bit of readjustment for me, because in the beginning I was horrified that the patient wasn't really even part of the decision making. It was like the family, and then they would come and tell the patient what was going to be good for them. Okay, so why is all of this important? We need to be able to maintain trust with our patients, absolutely. And again, if we don't have a conversation, if we don't put all the cards on the table and speak truthfully, then there isn't going to be trust. Uncertainty is a really awful place to be. I always think that bad news is worse than uncertainty. And then there's a conspiracy of silence, which is very common. My first case is going to talk to that. And obviously, we need to be able to help people determine their goals of care. So just to remind you, as I've said several times already in this talk, that good communication is one of the cornerstones of medical practice in general. And like the surgeon is great with a scalpel and sewing, we need to be fantastic in family medicine and in palliative care with our communication skills, because without information, people can't participate in their own treatment planning and they can't give informed consent. And of course, there's many different levels of communication. We need to be good at interviewing skills. We need to be able to ask people open questions. You know, I sometimes sit in or sat, now I'm retired in clinics, and I would hear my colleagues say, you have pain? No. You have nausea? No. Those are very closed questions. We need to be able to ask open-ended questions, and we need to be able to listen. I think one of the things that we do less well in medicine is actually listen to our patient. And people say, oh, I don't have time and all of that. I don't believe that. I think that we can do a great consult in 10 minutes. And that listening to the patient probably for 80% of that 10 minutes would be an important and successful outcome. There's different ways to talk about breaking bad news and so on. And there you see the final bullet point. I think that uncertainty is actually much worse than bad news, because then you're just in this limbo. Nobody gonna talk to me because maybe it's way worse than I thought. and so on. And then the family also will often participate in that and stop and ask the doctor not to share information, and leaving the poor patient in a very uncertain place. Even if the news is bad, then people can move forward. They can plan their funeral or give away their wedding ring to their granddaughter, whatever it is. But if people are not sure about what's going on, I think that really is a particularly unpleasant type of suffering. We don't have enough time tonight to talk about how we would break bad news, but the most basic, simple protocol that I suggest to you is ask, what do you know? What do you understand? What does this mean to you? What are you hoping for? Because unless you ask people where they are as a starting place, you don't know where you can then, what kind of information they need. So ask people where they're at, listen to what they say, share the information that you have to share, and then check back with them that they understood what you said and ask if they have any questions and so on. And always finish with a plan. Don't leave people hanging. Always have a plan, even if the plan is, let's continue this conversation tomorrow when I come and look for you, or when you come next week. But don't leave people with this open-ended situation. Have a plan, however simple it is, so that people have a foundation that they can work with. Poor communication. This one on the right, again, this raises this thing about, the suffering that was caused to me by the way the doctor spoke to me. If people don't realize that the care that's being offered can often be futile, life-prolonging care, then they may continue with it because they don't realize that the futility of what they're taking, and a lot of psychosocial morbidity, and also underutilization of what palliative care services or hospice services may exist in our countries if people are led along thinking, oh yes, this is still possible to cure this, when in fact that's not the case at all. But it would be back to the fact that they haven't had decent communication and understanding. And then of course there's a lot of moral distress, emotional burnout, and economic cost if we are also party to poor communication, not just with our patients, but sometimes also between colleagues. That can be really challenging. So there are endless ethical dilemmas at the end of life. So I'm going to touch on the principle of double effect, and I'm going to touch on the use of nephrostomy tubes, and maybe one other. I'm going to encourage you, please, to think about ethical dilemmas that you face in your practice as family physicians. And again, hopefully we can touch on a couple of those in the Q&A. Okay, so this is a very, very common situation. So Shirley on the left is 68. She's just been diagnosed with metastatic kidney cancer. Claudette, her daughter, actually heard the doctors talking in the corridor and hold on to you and say, Doc, don't tell my mother. And the standard thing that people say is, don't tell her because she'll go fret and she's going to die quicker. And I know my mother, she's a fretting person. Okay, so ethically, do you hear Claudette? Yes, this happens all the time. I'm sure it's very familiar to you. But your ethical responsibility is not to Claudette. Your ethical responsibility is to Shirley, because Shirley might actually say, don't tell my daughter, I don't get on with her, don't talk to her. Although in this picture, which is not of Shirley and Claudette, it's a nice picture from the internet, but they look like they get along well. But the real point I'm making is you need to be very, very careful that you don't break confidentiality with a relative that the patient doesn't want you to talk to. Very critical. I used to see this in the hospital all the time. So you need to talk to Claudette, to the patient first. You need to be able to say to her that you have some news for her, and that it may be difficult news, and would she like her daughter present? You also need to help support Claudette, because she's obviously worried that what's going to happen when her mother hears the news. And it's usually best, I find, to talk to them together. and explore what Shirley understands. Ask Shirley if it's okay to share the difficult news. And then there is a protocol. There's many different protocols for breaking bad news, which don't really have time to go into, but it's really important that this is done together, and that Claudette sees that if Shirley's okay with her being there in the first place, that it's not as devastating and terrible. And that Claudette also needs to know that you can't offer treatment to Shirley unless she knows what's wrong with her. So right there, you can't get informed consent from the patient unless she is fully informed. So there's many different levels to this, but please always try and remember that your ethical responsibility is to the patient, not to the relative. However much they're pleading and begging with you, you need to share with the patient. The patient may say, I don't want to hear the news, talk to my daughter. I've seen 5 people in my entire 30-year career who said they didn't want to know. So most people want to know, even if it's difficult news. So the second case, this is Desmond. So Desmond, 6-year-old man, metastatic prostate cancer, no longer responding to standard treatment, and he's admitted to the hospital with worsening cachexia, poor appetite, back pain, looks exhausted and uncomfortable. So here now he's admitted, and here's the team wondering whether we should put up a drip, whether, you know, he's certainly not getting the calories that the kind of classic standard person should be taking in. And so should we be putting an NG tube down? Should we be putting up an IV line? One of the things that's very important, I know Dr. Barnes wasn't really talking about end-of-life nutrition, but things change completely when people are coming to end of life. And the idea that you can feed people up by giving them plenty calories by an NG tube is, and that will fix the problem and stop them dying of their disease is a myth, sadly. But many, many families think and believe that if we can just feed him up, he'll be fine. So we have to talk all of these things through. So the benefits and the burdens of those options are discussed with Desmond and his family. And the IV that was up is taken down. We don't put down an NG tube, and we start him on some morphine because his pain is quite severe. The focus that was agreed at the beginning was we want to keep Desmond comfortable. So he gets some pain medicine, his pain is improved, but it's really not to the level that we could say is comfortable. But then the family are like, no, man, you can't give him any more morphine because that means we're going to be killing him. So here we are, we're trying to get Desmond comfortable, but the family are getting in the way and saying, no, 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 you can't give him more because that's effectively going to shorten his life. So how do we respond to that? So this is where we have to look at what we call the principle of double effect. So this is actually a very ancient principle that gives us support for deciding what to do when any action risks potential adverse effects. So the law of double effect, or the principle, it's not really a law, says that if you are giving something with the intent, like giving some morphine with the intent to relieve pain, the unintended consequence may be that he's more sleepy, that he takes in a bit less food and a bit less liquid, and possibly that may shorten his life. I know some people may be thinking, oh, it may reduce his respiration. That's very unlikely and very uncommon. And sometimes we use morphine to actually improve dyspnea. Quite a common use of morphine in palliative care. So what I'm really saying, the other thing that we often use is, let's say, midazolam or alprazolam or lorazepam to help with agitation, which may depress respiration and may, as an unintended consequence, people may be in more risk for an infection towards the end of life. But we're talking about really in the last few days here. So you can give medications with the intent to relieve suffering, recognizing that there may be unintended side effects, which are generally very, very unlikely, but we need to be able to recognize that that's possible and then to talk that through with the family. Because if you want your relative comfortable, we need to give them a bit more medicine. And so we would talk through not as we are talking about ethical principles like this, but just to point out that in order to get him comfortable, there is a small chance that we may be shortening his life. But in fact, in actual fact, that's very unlikely. And then I just want to touch on, I know time is running here, Paula, 33 years old young woman, unfortunately presented with locally advanced cervical cancer, right-sided hydronephrosis and deteriorating renal function. So she has a good performance status at presentation, and informed consent conversation, and nephrostomy tube is placed so that her renal function can improve. She gets her chemo radiation, renal function improves greatly, the mass is coming off her ureters, and so she no longer has an obstructing lesion, and the nephrostomy tubes can be removed and she can go back to a more or less normal life. Unfortunately, it comes back and recurs in the pelvis, now with bilateral hydronephrosis, lung mets, bone mets, severe pelvic pain, and a rising Bunn creatinine. She's in pain, she's drowsy, but difficult to have a conversation with her. And the relatives are saying, we need to put those tubes back now because we know that they will save her life. So how do we respond here? And I'm going to suggest that the response at this time is, what's the goal of care? First question, what's the goal of care? And that is probably to keep Paula comfortable because she has extensive disease, and putting in a nephrostomy tube, which is not a simple procedure, is unlikely to improve her quality of life. And so this is a whole conversation that we would need to have with Paula and her family. But I would suggest that the second time, the insertion of a nephrostomy tube would not be in this patient's best interest. And my last slide, I see Dr. Goldson on there. So ethical discourse should include curiosity, meaning let's find out what the patient wants to know. We need to be empathetic. We need to be aware of our own prejudices and our own concerns. And of course, we always need to see the whole person. So it's a complex process. Always have the ethical principles in the back of your mind, that specific communication strategies are important, but even just good communication, asking open-ended questions. And also, I just throw this in at the end, become an advocate for discussing these things with your own family before the serious illness reach, and then you're suddenly not sure what your loved one would like. A couple of references there, and I do thank you for your attention.
Thank you so much, Dr. Spence. Sorry I had to rush you a little at the end. We do really appreciate your taking the time, especially at such very, very short notice. As always, a very illuminating presentation, reminding us of very important principles that we should all be practicing at all times. Now, as we wind down, we have one other speaker. We have spoken a lot about the care of the patient, care of specific diseases, overall care of patients, ethical issues. But we recognize that the doctors or even the members of the health team who manage cancer patients themselves there is a mental impact. And to take us through this discussion, I want to introduce to you Mrs. Georgia Rose, who is actively involved in mental health education and early childhood development. She holds a Master of Science degree in clinical psychology, a Master of Arts in infant and early childhood development, and is currently pursuing a Doctor of Philosophy in infant and early childhood development. She has been providing service in child and adolescent mental health for over 19 years in the Western region, and in 2015 was recognized by the Special Education Unit of the Ministry of Education for unrelenting and untiring service to special education. She is actively engaged in community service in Western Jamaica as a consultant on the Ethics Review Board for kidney transplants, past chairman for the St. James Red Cross, and past board member of the Peace Management Initiative of St. James. Georgia has conducted numerous psychosocial support training across the Caribbean on behalf of the International Federation of the Red Cross Disaster Mental Health Unit, especially with a focus on the impact of trauma on children and adolescents. She lectures psychology at the undergraduate level at the University of the West Indies Western Jamaican campus and has presented on numerous topics related to child and adolescent mental health. She has delivered hundreds of lectures on mental health and wellness and is currently compiling a book on strategies for positive parenting. She is passionate about mental health and wellness, and while she supports all clients, she enjoys working with children and women the most. Tonight, she is going to speak to us on the mental impact on physicians when managing cancer patients. Ms. Rose, over to you.
Good evening, ladies and gentlemen. Thank you so very much for having me. I have been tasked with speaking to you about the mental impact on physicians when managing patients diagnosed with cancer. And I promise I won't be very lengthy. I hope it will be short and impactful, and you will walk away with a few gems that you might already think about in your everyday practice. When we think about caring for any patient that might have a demanding illness that has the possibility of terminality at the end, we have to appreciate that it naturally impacts. I think anyone who goes into the provision of healthcare has a heart behind it. Some of us might have larger hearts than others, and an intentional desire to do good and to help others. So working with patients diagnosed with cancer is not necessarily different than working with any other patient that's diagnosed with an illness that we know has a potential to take life. And I think we all appreciate that the diagnosis of cancer can be quite a heavy one to receive. Physicians, when you think about it, walk with their patients in an intimate journey throughout the diagnosis of cancer. It is more than just saying you have cancer. It's about how the cancer changes and impacts the life not only of the individual who is directly affected by the illness, but the family, the community, and the society that that individual exists in. And it is very hard to extract yourself from the lived experience of the individual who is going through this difficult journey. And we know that receiving the diagnosis of cancer means so many different things to each individual. Cancer meets people at different stages and points in their life. Years ago, a dear friend of mine was diagnosed with cancer before she had turned 30. And I remember her struggling with what was the right decision to make. And one of her physicians knew me, and he reached out and he said, listen, Georgia, you might be the only one she's going to take advice from, but you need to tell her that she has to take her breast off. She has to remove her breast. And I said to him, I don't want to have that conversation with her. I don't want to be the bearer of that news. And I invited her to come and sit with me. And I said, you know, Dr. So-and-so rang me and he wanted me to tell you that he really believes it's in your best interest to remove your breast. And she said, Georgia, I don't have children. I don't have a partner. You know, when I take my breast off, which is so much of my identity as a woman, what do I offer to someone? And I don't think I'd ever thought about it that way. You know, as much as, you know, you're a clinician, you're a therapist, you're sitting in the chair and you're listening to people's struggles, sometimes until someone puts it very plain, it's very hard to fully appreciate it. So is it for the physicians who sit on a daily basis meeting clients on these different walks, you know, these different points in their journey. Some people might be much older and might feel like, well, I've lived a full life, so this really doesn't stop anything. Some people might think that they have the world before them, that they want to conquer so many unfulfilled tasks and unmet goals and dreams. You know, some people don't have anyone relying on them, while some individuals have children. So it's such an intimate process no matter how much we try to remove ourselves from it. So I think we can understand, we can hold space, we can think a little bit further that it does have an impact. You know, you would have to be made of stone to not be impacted. And I go a little further and say affected by the immense demands that this diagnosis may bring into someone's life. When we think about mental health and wellness, I always want to remind individuals that mental health is not synonymous with mental illness. When we speak of mental health, we are trying to prevent, to discourage, and to decrease the likelihood of one's susceptibility and development of a mental illness. None of us are immune to the presentation of symptoms associated with a mental illness. And so for individuals like our healthcare providers, primarily our physicians, who are in the trenches and dealing with the demands of major ailments such as cancer, we want to know that it can be extremely taxing. You have a front row seat. You know more than so many others. You know the intricacies and the complexities that come with the diagnosis. Oftentimes we hear stories of individuals who receive the diagnosis and choose not to share it with their loved ones, and they co-opt their physicians into this secret keeping. The physician is now placed in such an uncomfortable position to dialogue with loved ones when they do enter into the clinical space without betraying the trust of the primary client. So it is such a difficult journey that it is mentally taxing on those who engage in this type of patient care. So I put up this little I want to call it a little flow. And I struggled with the last term a lot because I wanted it to convey what I really meant. When the patient first enters into our space or into your space, you are tasked with giving the verdict. Do I have cancer or not? Knock on wood, right? And you stand in that place of authority, and the patient has bated breath because they want to know, what is it, doc? What did the results show? And you get to say, this is what your diagnosis is. So you start off in a very authoritative space, and you hold in that moment the tangible proof or evidence of whether or not this individual's entire life is going to be upended by this diagnosis. And you get to say the possibility, the prognosis, you know, the evidence says you have 20 years, 10 years, 10 months, 5 days. So you are very much like a juror in that moment. And it is a very heavy news to receive, but it's also very heavy news to give. And I read a few articles, you know, I was trying to find research that spoke about the mental health impact on physicians when they have to deal with heavy ailments such as cancer. And it spoke about the difficulty that some physicians face in sharing the diagnosis. The research said or suggested that younger physicians struggle with presenting the news because of the pain and the impact that they envision. More seasoned physicians also struggle with the news because they've done this so many times, and they don't have the privilege of ignorance. They actually know. They know what the trajectory is going to look like. And sometimes the knowing is not so great because you want to give hope. And in that moment, you may not feel very hopeful. So you stand as juror. You progress from that stage as juror into almost the savior because you are providing care. And once again, the young, the eager, the novice physician goes about providing the care with this belief and this intentionality that you're going to get well, you're going to be healed. Nobody enters into treatment if they don't believe it's going to work. And I would like to think that no one offers treatment if they don't believe it's going to work. Once again, the novice professional or the novice physician enters into the treatment, administering the care because they believe it's going to work. The more seasoned physician may not be fortunate to have those feelings of hope. Then as we move along the journey, we might find ourselves in a space where we're praying with the patients because the treatment is not able to save or to rescue. And this is a very difficult place to be in. And some of us may turn into pastors and spiritual mentors. And we recognize that, the earthly attempts are not going to make much of a difference, but we want to provide some amount of reassurance for our patients. So we're seeking hope in many different places. And finally, our physicians might find themselves, I wanted to say human, but it's so much more than that. You become so entwined and intricately linked. This is someone that you've been seeing consistently for months, for years. You've heard their fears, you've seen them weep, you've seen them turn red. You can see that they're terrified, they're scared, you've had their loved ones there. By the time you get to the end of that place, and the end can be something good. The end can be something positive. The end can look like, you have beat this. You are in remission. Your vitals are really good. Your levels, your numbers are great. You are on the road to recovery. By the time you get to that end place, for the moment, you are more than just a physician. You are so valued to your patients. And for all of us, no matter what is your specialization, no matter at what point you meet the patient, no matter what the degree of care that you might offer, the patients, once they feel connected to you, once in their mind they have written you in their story as someone who contributed to the possibility of their healing, they value you on another level. And I think if we're honest, so many of us come to a place where we value our patients too. Where they get entwined in our story. We're motivated by their hope. We're saddened by their losses. We see their struggles. We are part of the highs and the lows. So you get into a place where you're either in mourning with them, or you're anticipating the morning, or you're rejoicing with them for the possibility of what could be and what can become. Now, if you do this quite frequently over a series of years, and some of you might even have decades under your belt, how does that affect you? How does that touch the core of your mental state? What is the psychology, the mental stuff within it? The research tells us that physicians find themselves employing a number of strategies in an attempt to cope with the demands of an illness like cancer in their patients. Some physicians become very detached, and you will have patients coming to tell you they're very cold. They have horrible bedside manners. I don't think they really care. And it's not that you don't care, but you care so much that in an attempt to protect yourself, you put up a wall and you step away. And you see the patient as a case number, as a research statistic, as a finding, as a disease progression. You don't see the human, and you do not relate to the patient as a human. So we get that detachment. And I think I can appreciate that to some extent. There is a degree of detachment that is needed to effectively carry out the job, but we can also understand and acknowledge how that detachment can remove the humanity from the job. Then you also might find that you have burnout, because so many physicians try to be so much more to their patients than a physician that you might be doing a little bit too much. I often wonder, how do physicians manage when patients have their phone numbers? And, when people think they're going to die, the fears become very loud. When COVID, was most rampant, one of my tasks was to provide psychological support for individuals who were in quarantine. And I can tell you, those individuals who thought they were going to die were some of the most demanding cases. And at the time we were doing virtual sessions, so they had other ways to contact me, outside of through the hospital as it would be previously, and they would contact very often. Miss Rose, can we speak today? Can we speak tonight? And I would have spoken to them maybe in the morning or the day before, but just the fear of no longer being around. And if you avail yourself a lot to your patients in that manner, it can take a toll on you. You know, one of the things that I've learned is that, you know, it's good to just stay in my lane. You know, I want to do everything for the patient. You know, I want to, patient doesn't have a job. I want to say, you know, maybe you can do this. But then I have to remember, no, we've got a social worker for that. I have to let the social worker do that. Because if you try to do everything that your heart wants to do, then there'll be nothing left of you to give back. So many of our physicians struggle with burnout. And you see the burnout in different ways. You might also find the research says that physicians become resistant. You know, they don't want to do the work. They don't want the extra patient. No, I already have 10. I don't want 11. You know, no, I'm not going to carry over that blood. Let the nurse come and do it, or the attendant. You know, no, I can't. You start to resist. You know, there's a pushback. And it is a survival response. It's not because you're a bad physician. It's not because you're a bad person, but you're overwhelmed. You're spent. There can also be resentment. You know, why is the patient not getting better? I've poured my all into this individual. I have read every journal. I've looked at every novel study. I've done everything. It's, you know, the patient is not adhering. And if the patient had just listened, you know, and if we think about the stages of grief, you know, the death, the denial, the anger, the bargaining, the depression, and the acceptance, we also go through that. You know, I was speaking to a client who had lost a loved one to cancer, and we talked about how, you know, people were very angry when this person died. It is normal to be angry and, you know, and point fingers at each other. It's the doctor who killed them off. It's the chemo who killed them off. And we get it. We get the vitriol. You know, the patients come and they cuss you out. Is hospital kill off the patient? And if you never give him this, and if he never listen to you, and if you have to deal with those things on a consistent basis, you get resentful, especially if you feel that you've done your best, you've poured your all into it. You know, you're going above and beyond. How could people really say I didn't do my best? So the resent comes in, and there comes the irritability and the annoyance. You know, what else? What is the patient complaining about? What is the other doctor asking me to do? What is the nurse asking me to do? And you find yourself becoming less tolerant. You find yourself being less willing to listen. You find yourself being short. You know, you just want to get it over with and done. And some people might say, you know, I remember a physician said, they're going to die anyway, so why am I killing up myself? And this, of course, was a statement made out of pain, you know, watching a patient die and hoping that that would not have been the end. And if you do it long enough, and if you see enough deaths, and if there isn't healthy pauses in between, then you can get into a place of hopelessness, where you are just going through the motions, administering the care, but you really don't have any hope that the patient will live. And some physicians who hold a faith will also question their faith. You know, what am I believing in if ultimately, after all my efforts, the patient will pass away? I want to remind you that on the one hand, you are a physician and you have to be a physician. The patient needs the information. The patient needs you to be solid and convincing and confident in what you bring to the table. They need to be able to buy what you are selling. But within the physician, there has to be a human. And the human behind the care is integral to the care. If you take yourself to a place where you do not allow yourself to feel, to understand, to mourn, and to acknowledge the gravity of what you're dealing with, all you have left is a shell. And a shell doesn't impact people in the same way that a human does. You would be amazed at knowing that you understand the difficulties within which they toil within that moment makes a difference in how the patient goes through their journey. We can never be replaced by machines because machines will never be humans. Maybe in the future, machines will diagnose cancer. Maybe in the future, machines will even care for patients with cancer. But a machine can never supersede a human when you need that human element. And I am a firm believer that when you get ill, there's nothing like the human element to get you through it. The ability to intentionally seek to understand yourself through the process is critical to your own emotional well-being. Each of us as clinicians in our various fields, especially yourselves as physicians, owe it not only to your patients but to yourselves to do a self-check-in. How am I doing? Do I need to step away for a moment? I remember years ago, a senior psychiatrist said to me, "This is not a field to live in." And I didn't understand what he meant. And he said, "Georgia, if you listen to patients struggling with depression every day, you will become depressed." He says you must take breaks to pause your mind, to refresh your spirit, and to come back. And I have grown in the past 21 years to understand that. I've been with the hospital 19 years, but I've been practicing for 21 years. And I have that greater appreciation that if we don't step away and recharge ourselves, we do a great disservice to the people who rely on us the most. If we are caring for patients and we're not at our best, are we really providing the best care? So the intentional attention to self is critical in the provision of care. How am I doing? And how do you provide care when you yourself may also be going through your own struggles? One of the case studies that I read that spoke about physician mental health well-being spoke about physicians themselves who have had to dance with cancer in a personal way. Physicians who've diagnosed with cancer have been able to beat the odds and are in remission and are then expected to provide care for patients with cancer, have to be especially careful that they are caring for self in the mental health space. Physicians whose loved ones, your parents, your siblings, your spouse, your children may also have ailments such as cancer. How do you survive in a space where you are caring for others with the illness while you're caring for your loved ones? So we constantly have to be checking in. We also have to remind ourselves that every patient is different and every patient has a unique story. And therefore, you will find that your response to each patient may also change. Some patients pull different things out of us. Some patients pull the greatness, and some patients make us have to remind ourselves why we're doing the job. The familiarity of death is not necessarily a healthy one. Seeing death and being on the journey of death and having to stand with individuals as they go through the reality of their mortality can be something that chips away at you. You have to ensure that while that is the reality of the service that you provide, and you would have signed up for it, we know that, while that is the reality of the service that you provide, that you are taking care of the life that you are living, because you are a part of the lived experience right now. So how are you coping with the death? I want to ask you, and of course you can't answer, whenever you have been caring for a patient who then passes away, do you have a routine that you engage in to heal yourself? Or do you just say, well, they died and move on? I don't necessarily know if that's healthy, I think that's what a lot of people do because that's what we have to do, and especially within the systems that we work. But if we think about it in the long term, I don't necessarily think it's the greatest. Maybe we have trained our minds and psychoneurologically, we are not distressed by it, but maybe in the long run, it's like little tears that finally become big cracks, that become huge separations in our mind that compromise our mental stability and well-being. Please to seek balance in your daily life. All of what I read consistently recommended and reminded that we have lives outside of the job, and the best physician is a healthy physician. And when we speak about a healthy physician, we're not only talking about physical health and well-being, we're also speaking about mental health and well-being. What are the things that bring you joy? What are the things that you love? What are the things that give you peace and pause and help you to reset? And for each of us, that balance is so different. You know, as much as we want to be there for 100 patients, we also have to be there for ourselves and our immediate loved ones. Set aside time to have some ice cream. Set aside time to sit and smell the rain, to look at the sky, to read a book, to go to the beach, to take a break, to take a break. And if you're like me, I struggle with taking the breaks because I worry about the patients. But I also know that stepping away is so important for myself. And the patients, they love you, they pray for you, they want the best for you. You know, they look forward to seeing you come back and you come back with a smile. So seek that balance, you know, be there for the people that need you also. We can't be out there rescuing everyone and forgetting about our family and those that are within our immediate space. Attend to yourself. So actively find opportunities to balance these heavy demands. And of course, I always want to remind everyone that there is absolutely no good health within this world if you do not have a good mental health. Thank you so very much.
Thank you so very much, Mrs. Rose, for that very important talk. I think it is what we would call the icing on the cake of what have been all excellent presentations this evening. You reminded us that while we are physicians, and I would extrapolate to other healthcare workers as well, we also are human, and that we have to always maintain the human touch, that we should do regular self-check-ins, and that we need to take balance breaks and have balance in our life. So thanks very much for all those words of wisdom. The night is well spent, but I am going to give just 5 minutes. We do have some questions that we want to put to our panelists, the last three who presented for us. I am going to put 5 minutes on my timer. I'm going to, I don't think we can answer all of them, but let's try and get through a few. Raquel Turner was asking Dr. Barnes, what are your thoughts on the keto diet, removing carbs or sugar from the diet? It is widely mentioned that most cancers feed on glucose, but what are your thoughts on this? Dr. Barnes.
That's a good question because keto is really big right now for weight loss. And I think that for cancer, we have to think about, again, what we need to do to prevent cancer, separate from what we need to do when we've already been diagnosed. So some of the things that I touched on, the keto diet, unfortunately, would be really difficult for some of the patients. Like if people have a solid tumor that is causing obstruction and all they can consume is a soft diet, or all they can have is shakes. Keto diet is going to be maybe a little difficult for them because, you know, those things usually have carbohydrates, mashed potatoes, mashed bananas, maybe yogurt, which isn't in keeping with keto. Outside of that, though, we know that states that are high in insulin cause a lot of inflammation, and that inflammation can often lead to the development of cancer. And people who have high blood sugar levels in general, and people who have diabetes as well, have an increased risk of cancer. So there's probably something there with the prevention of cancer, yes. But then when you've already been diagnosed, I think a little bit more work has to be done on what is the most appropriate thing, and whether or not something like keto could be helpful.
Thanks for that. Following on, another person is asking, for patients, females diagnosed with grade 1 hepatic steatosis, what lifestyle changes would you recommend?
I think hepatic steatosis might be a little bit outside of my realm of oncology, but I know for sure that there is recommendation regarding weight loss, lifestyle change, exercising to try to diminish the risk of progression. But apart from that, anything more specific, probably I would have to ask somebody from internal medicine to help.
Sure.
Mhm.
And I'll give you just one more and then move on. So someone is asking you, how does coconut oil compare to olive oil in a healthy preventive type diet?
So, coconut oil, there have been a lot of conflicting studies about it. I know one of the main compounds that has been studied is one called the lauric acid, and the lauric acid in coconut oil has potentially been found to decrease the risk of cancer. But then there are also studies that show that coconut oil has a lot of saturated fat. So it's a little bit confusing sometimes, and unfortunately, because the coconut oil is what is used in I guess developing countries, and the studies are not being done in places where coconut oil is very common, we don't have a lot of information for ourselves. So most of the information we know is anecdotal, is based on the fact, well, my grandmother been using coconut oil all her life and she's 105. So hopefully we will be able to do our own research as it stands now. I would say that it's an appropriate choice. And that probably the most important thing about it is what you're using the oil to do. Are you using the oil to fry food every day to eat, or are you using the oil to saute vegetables? Those choices are probably more important than the type of oil specifically that you're using.
Right, and you did mention in your talk the importance of how we prepare foods. So we always have to remember that. There are a few other questions I'd ask you to look in the Q&A, and if you could type in the answer to the ones I haven't asked.
Okay,
Going to
no
move
problem.
on to some for Dr. Spence. Martin Taylor says, I had a client with cancer being treated. I never told her family. The same day I met her, she fainted in the pharmacy, having just left my office, having insisted that I don't tell her children. She was returned to my office. Should I have told her relatives of her malignancy? Dr. Spence, how would you respond to that?
I think, we do, it's a difficult question, but we do actually have to respect the patient's wishes. But I think that in the conversation where the patient is saying, don't tell my family, why can we tease that out? You're going to need support as time goes on. Are there a couple of family members that it's okay to tell? So I think rather than just going, okay, I won't tell your family, it's to explore that curiosity, explore what's behind that.
Yes.
And it may then become clear they may still insist that they don't want family to know, in which case you are bound by confidentiality. But it seems that if the universe stepped in now and she has fainted, so somebody in the family is going to have to come and support her and so on. But I think always it's exploring the reasons why people seem so adamant about not sharing their information. Yeah.
Right. I probably trying to get them to the point where they will then agree. Again, as you said, the whole communication with the patient. Professor Bain is thanking you for your presentation, and he says that a relative of a terminally ill patient appears unwilling to accept the inevitable outcome and insists on feeding up the patient. How can the physician help both the patient and the insistent relative? You touched on this. You want to expound a little more?
Sure. So talk to them. So basically, I think it's important for people to understand that when folks are getting towards the end of life, they naturally don't need that many calories. They naturally move from what we would call regular tough food that you have to chew to softer foods and then eventually to liquids. And that's what they can manage. There's no point in trying to give Burger King and Kentucky Fried Chicken and pizza and oxtail and red peas to somebody who's very weak. So I think it's helping the relative understand it's not about giving up, but it's about shifting what we're providing for the patient, because the patient is going to be the first one going, sorry, I can't manage. And we have to remember that the muscles of chewing and swallowing are skeletal muscles, certainly the muscles of chewing. And if you're so weak you can't hold a glass because you're, at that stage, you're not going to be able to chew no matter what your relative wants you to do. So I think it's working with them both, helping the relative to understand that the patient is dying because of their disease. They're not really dying because they're not eating, and help them support the patient in what the patient can manage. And so that it's you try and bring people together to provide the best for the patient.
Thanks very much for that, Dr. Brown Morgan. I see you've typed in something. I'm not going to read it all, but I'm going to ask that people just take a moment and read what you put in the Q&A, sharing some of your experience over your 30 years of practice. I am not seeing any other questions. I don't know if I've missed anything, Sam, but I don't think I have. And I know that
No, you didn't miss any questions.
Good.
Yeah.
I know that I feel that the last 3 to 4 hours for me have been well spent. And I hope that those others who are on the call also feel so. I will not steal Dr. Levy's role. Dr. Dane Levy, who is an executive member and secretary of CCFPJ, has been tasked to bring the vote of thanks. So I'll ask him to do that at this time. Dr. Levy.
Good evening, good evening, good evening. Truly a tremendous evening where we have been treated to the multidimensional approach to the treatment of cancer, several different approaches, and all very interesting. I would like to take this opportunity to say thanks on behalf of the Caribbean College of Family Physicians, who so ably, led by our president, Dr. Seni Onanuju, in putting together this webinar. Of course, also with the support of the administrative staff, led by Ms. Lynn Thompson Hyatt, and all the other support staff she has. And of course, our moderator did an excellent job. Dr. Aileen Standard Goldson, you did an excellent job moderating and leading us through this very long but very interesting webinar, in which I think judging by the comments, everyone enjoyed, learned a lot, were kept up on their toes and up to date, and all the different new modalities of treatment, approaches, from all different angles, truly multidimensional. But let me specify who I'd want to give thanks to, in addition to the presenters, definitely. Dr. Jason Copeland was opened the inning, so to speak, and dealing with the breast cancer in men and women. Consultant and oncologist Dr. Jason Copeland did an excellent job. And of course, Dr. Riyad Ghaffar, consultant urologist, who did this thing on prostate cancer. Very, very interesting, the developments that are, and the different approaches to treatment that are being used nowadays. The screening for cervical cancer, the role of HPV, by Dr. Natalie Medley, consultant gynecologist, oncologist. This one was also very, very interesting. The role of HPV, the stepping away from just the use of the pap smear as a means of screening, now to more specific role, this more specific role of the testing of HPV, and of course emphasizing the need for our children and our young adults to get their HPV vaccines to prevent this dreaded disease. That could close the first half of the webinar, and then Dr. Tony Barnes so ably started off on the second half, and she dealt with the nutrition in cancer patients. And that is something that we as family physicians are faced with every day, when our patients ask questions of us of what to eat, what not to eat. And I think she dealt with that in a rather comprehensive manner. And that's something that also helped us to benefit and to develop strategies in the approach as to how we should answer or we should advise our patients. Ethical considerations in terminal cancer care. And of course, Dr. Natalie Sharp should have taken that, but Dr. Dingle stepped in and did an excellent job, I think, in dealing with the ethical considerations in terminal cancer. And this is such a difficult topic for us all. When our patients whom we have been caring for so long, and when we see some of the cases, they are so distressing and there's so much that we have to deal with, so many different angles from the family, from the person, the personal aspect of it, the patient aspect, and also now just the whole ethical considerations of the family dynamics and all of that. And then we came to the last presentation, the mental impact on physicians managing cancer patients. How do we take care of ourselves so that we don't burn out and so that we can be the best physician of our patients, offering our patients the best kind of care? Because that's what this is all about, isn't it? Being able at all times to offer the best kind of care. And I think the takeaway from our presentation was that we must remain balanced. We have families and we have other aspects of our lives that we need to keep us balanced. And I think she really capped off that this evening's presentation with a really comprehensive and impactful presentation. Overall, an excellent webinar. As I said, a bit long, but indeed we are kept on our toes and we're kept, very, very informed. And everyone who presented this evening did exceptionally well, I think. And I think I'm just reflecting the thoughts of almost 500 participants in this evening's webinar, almost 500, and everybody seemed to have had something good to say about these presentations. So I want to thank, it was Ms. Georgia Rose, the clinical psychologist who did that last presentation. So I want to thank overall all our presenters. They did an excellent job. And of course, I want to thank Sam who kept us on the platform, who helped to manage the running of the webinar, and who, of course, in his usual professional manner and always so calm, of course, and so qualified and so capable. I think he also did a very excellent job. I'm hoping I didn't miss anyone, but I would just want to thank everybody who participated. Of course, without my colleagues who joined on, the webinar would not have been as effective and it would not have been as impactful as it was. So I want to thank the colleagues who joined as well. And of course, to thank God, because without him, none of this would be possible. And I would just like to just say thanks to all who had an input into making this evening's webinar the success that it has been. So on behalf of the Caribbean College of Family Physicians, thanks once again and good night. God bless you all.
Thanks. Go ahead, Sam.